Just give us like a few seconds.
Hello. Yeah, hi doctors. We'll be going live in about 2 minutes. Pushpindu ready?
We can stop the screen share initially.
Yeah.
So we are ready to be live. Pushpindu ready?
Vijay, I'll be sharing a couple of clips, slides to introduce you before you start sharing, just for information.
Okay.
Once sign finishes, I'll be sharing the screen, then you follow me.
Okay.
Thank you.
Doctors, we are live. We can start. All right.
Yes.
Okay.
Yeah. So start.
Good evening, everybody. This master class is to give an example of how surgeons can be helped to the endoscopist, and endoscopist can do the same for the surgeons. Surgeons and endoscopists should always work hand in hand, and they can be helped to each other in difficult situations. So this master class will show how we can help each other, and this will be the last but one master class for this year. Next master class will be on thoracic, which will be held. This will be next the last but one master class for this year in due time. Next, so I hand over the proceedings to Dr. Ishwarmurthy,
will be
our next
the last
pulmonary
but the one
secretary,
which allows for
who
this
is also a
in
master
due
endoscopist.
So
I hand over
the
to Dr.
proceedings
Ishwarmurthy,
this will be
our next
the last
pulmonary
but the one which
secretary,
allows for
who is
this
also a
in
master
due
endoscopist.
So
I hand
hand
over
over
to Dr.
and,
Ishwarmurthy,
see my slides
will
now.
be
next
the last
pulmonary
but the one which
secretary.
allows
We can
for
see
this
this
in
on
due
screen.
So
Good
hand over
afternoon,
to
my dear president, respected seniors, faculties, and IAGS members, ladies and gentlemen. On behalf of IAGS, I'm pleased to welcome you all of you for this endoscopy masterclass, the fourth in line today for the next 3 hours. Thanks to Sayanda for introducing the topic. I bring greetings from our founder, president, and all our EC. And today's topic is endoscopy for laparoscopic surgeon, friend or a foe. And we have a galaxy of speakers across the country on 5 different sessions to give you a taste of what endoscopy can offer to the laparoscopy platform. Because most of you, if not all of you, would be choosing laparoscopy as the path to go in your destiny as a surgeon. Only few of us are taking the path as an endoscopy. Endoscopy by the surgeon is a path less traveled nowadays, but I'm sure at the end of these 5 sessions, you will realize the statement I am making, that is, endoscopy is not just optional, it is going to be an essential for every laparoscopic surgeon. With that, I'm going to invite my first panelist, endoscopic rescue, how it could be for various laparoscopic complications. To do this rescue, I request Dr. Vijay Borgankar along with our President Ramen Goel. Vijay Borgankar is our EC member from the West Zone in Aurangabad, and we have an expert panelist, Professor BKR from Chennai, we know, and Dr. Vipul Rathod and Amol Bapaye, who are all on their own right, might in their own specialty as an endoscopist. So we are going to have a very important, interesting discussion on case capsules, and I request Vijay Borgankar to take over from me. Over to you, Vijay.
Yes. Thank you, Ishwar. At the outset, hello.
Yes,
At
you
the
can.
At the outset, I appreciate the gesture of our president for involving me in this panel. And today I'm going to discuss the rescue operations which can be performed when there is a complication after the laparoscopic surgery. Fortunately, we are blessed with a wonderful panel. They are all experts in their field. And I will start with my first case with a laparoscopic cholecystectomy done. And on second post-operative day, patient had a biliary colic and there is tenderness in the right upper quadrant. Patient is not doing well. At this moment, I will request Professor B.K. Rao to comment that how shall we proceed with this situation.
The first point that we have to look at is whether the patient had a drain put after a cholecystectomy, whether it was an easy cholecystectomy or there was a lot of adhesions. Once we know that and the patient has got a biliary colic, we do the lab investigations, particularly the alkaline phosphatase, whether it is raised. Second important thing is to do the ultrasound examination, and if it shows that the bile duct is dilated about 8 millimeters and above, and a shadowing with the presence of a calculus, then we are sure that we have a calculus biliary colic. Once we have done that, we have got to proceed to the next step.
Yes, sir. Thank you. This patient had leukocytosis, LFT was mildly deranged. And as you said, the patient had a dilated CBD with a calculus in the terminal CBD. The further patient was treated for an ERCP. Sir, shall you please comment on Dr. Rao, sir?
Yes. See, the ERCP should be done as early as possible because once you remove the obstruction, the back pressure in the biliary system is reduced or comes to normal. Hence, the leakage, wherever it is from, either from the cystic duct or from any opening made will automatically close. Usually, once there is a biliary leak and the contrast is extravasating into the peritoneal cavity, then it is advisable to stent the bile duct to allow the bile to freely pass into the duodenum. And this will automatically reduce the intrabiliary pressure and the escape of bile into the peritoneal cavity. And that will result in automatic healing in 4 to 6 weeks' time. Again, we have to see what is the bilioma that is left behind. If it is more than 100 cc's, percutaneous drainage of the bilioma is essential because bile is a very good
Shall we put a drain? Shall we put a stent in this case after the stone removal?
After removal of the stone, we have to put a stent because
Now,
yeah, go ahead.
I request Dr. Amol if he can have any comments on this.
Yeah.
Amol
Thank you,
Bapaye.
Dr. Borgaonkar, and thank you, Dr. Ishwar, for this wonderful opportunity. Yeah, I would just say one thing, that we've not seen the cholangiogram of this patient. Now, if there is no biliary leak, because this is just second day post-operative, and actually the history did not mention whether there was any bile in the drain. So if there is no bile in the drain and on ERCP, on the cholangiogram, there is no extravasation of bile, then after a syncrotomy and stone extraction, I may choose not to put in a stent in this patient, because otherwise this patient will require another procedure for removal of the stent at a subsequent date. But of course, as Professor Krishna Rao mentioned, if there is bile leak or if there is extravasation of contrast, then a stent definitely is mandatory.
Thank you, Amol. It's a good thing. And this is one of the common things that we see, that after a lap chole patient has a biliary colic and there could be a residual stone. And this is how here we have seen that endoscopist has become our friend in managing this problem. Now, my case 2 is an elderly patient who underwent a lap cholecystectomy for acute cholecystitis. This is an acute setting. And post-operatively, he had pain in the abdomen, tenderness, tachycardia, and surgeon had left a drain, and the drain was draining about 300 ml of bile. Now, at this moment, I will request Dr. Vipul to comment. How shall we proceed with this patient?
Well, I think as Professor Rao had already mentioned, we definitely need to have a look, ultrasound and some blood investigations are required. If there is definite evidence or no evidence of stone, suppose in the bile duct on ultrasound, but if there is substantial amount of collection or drainage of bile, then I feel that we can do the procedure and salvage the situation. There are times when, if it was a difficult gallbladder, if there were adhesions around the gallbladder, and if there is some acute, purulent or suppurative cholecystitis because of the stone, sometimes the duodenum also is very edematous. So we have encountered a little difficulty in such situations to enter the bile duct in few cases. So one has to keep in mind, if your ultrasound is showing large collection or perhaps stone, then there is no discussion. We need to intervene. Even if there is no stone in the bile duct seen on ultrasound, and if the leak is there and which is not reducing, because in few patients, if you wait for a few days, then the leak subsides if the stone has passed out. But if the leak persists, then I think it is better to have, especially in this case where tachycardia, tachypnea, and all the other things are present, all the clinical signs and symptoms of biliary peritonitis, I think we should immediately intervene with the ERCP. And
intervention, would you like to do some imaging?
So that's what I said. We will do a hematological workup and imaging in the form of ultrasound. We may if you are suspecting some kind of a biliary injury, if the gallbladder was very difficult and the surgeon was not very confident, And then sometimes you may add an MRCP before you do any invasive procedure. But if it's a stone disease and is not much of dilated intrahepatic biliary radicals seen on ultrasound, I would go straight with the ERCP and solve the problem.
Yes. So in some situations, we shall perform the MRCP before subjecting the patient for the ERCP, but ER should be done as early as possible.
Correct.
For the benefit of the patient. In this case, ERCP was done and there was a leak from the cystic duct.
Yeah.
Dr. Amol, would you like to comment on this?
Yeah, Dr. Borgaonkar, one point I would like to make about the MRCP, in case we have to do an MRCP in this kind of a situation. Very often, if there is a large bilioma in the subhepatic space, imaging of the bile duct becomes very, it's not very optimal. So drainage of the bilioma percutaneously followed by the MRCP is usually a better approach rather than straight away going for an MRCP in this kind of a situation, because otherwise we will not get a good imaging. Of course, now if there is a cystic duct stump leak, here we can see that you can see that the bile duct continuity is well maintained and there is a leak from the cystic duct stump. Now this kind of a situation is best salvaged by a wide sphincterotomy followed by placement of a stent or a nasobiliary catheter, one of the two things. I personally prefer to put in a stent because it is more convenient for the patient. However, there are some people who prefer to put in a nasobiliary tube because it can be pulled out and the leak can also be monitored and it can be followed up to confirm that the leak has stopped. But it becomes a little bit difficult for the patient to manage the tube in the nose. What is also important is the stent in this kind of a situation, because the bile duct is not very dilated. One should preferably use a 7 French stent rather than a 10 French stent, because a 10 French stent very often will remain very tightly impacted within the intrahepatic radicle. It may in fact get compromise the drainage and the leak will persist. Another important point in this situation is that the proximal end of the stent should always be either in the common hepatic duct or more proximal in the right hepatic duct, and it should always be bridging the cystic duct opening. That is very important for the bile leak to subside very rapidly. Post ERCP in these situations, it is advisable to follow up these patients in the hospital, monitor their vitals as well as blood counts, and if required, repeat an ultrasound. If there is a residual collection, aspirate it or put in a drain over there. That is very important.
I'm sorry. How long would you like to keep this stent now?
The stent would typically be kept inside for about 4 to 6 weeks. Usually that period is adequate for healing to occur. And in fact, if the healing has not occurred in 4 to 6 weeks, then probably it means that there might be a major duct injury which has been missed at the primary ERCP. That is something that one should suspect, because sometimes doing an ERCP in this kind of a situation, it is quite compromised. Patient is also quite sick, and so the biliary anatomy may not be very clearly visible at the time of the first ERCP at all, and that can lead to some kind of controversy later on.
Yeah. Okay, Vipul, I would like to ask one thing.
Yeah.
That was a cystic duct leak, but sometimes there could be some different problem. There could be major bile duct injury. There could be a directly injury to the common bile duct, maybe partial, or it could be total, or there could be a right hepatic and the left hepatic and so on. So according to you up to which level you feel that the endoscopic management will help to the patient?
See, if there is no clear-cut transection of the bile duct, where the surgeon has ligated from just below the common hepatic duct with a clip, and the clip below, and there is a T-junction of the cystic duct and the bile duct missing, only in this kind of a situation you will have to wait and do something. But if there is a partial injury of the duct, I think if your contrast and if your guide wire can be negotiated across the leak, then in most cases, I think endoscopy can solve the problem of the lateral wall injury of the duct.
Yes. Thank you, Vipul. So most of these biliary leaks perioperatively, they can be successfully managed endoscopically, and only when there is a complete transection or there is any vascular injury associated and all that, in those cases only the major surgical procedures could be required. So this case was managed with the stent and the patient was all right. Now,
Just to
Dr.
add
Rao,
one
could
thing,
you...
Vijay, if you allow me to
Yes.
put one point here. See, there are enough studies worldwide now that the biliary injury and strictures can be managed effectively with endoscopy. And we know that after the liver transplant era, where all post-transplant strictures are managed endoscopically. So we have come to this term now where endoscopy has a mainstay unless there's complete transection and a missing T-link of the duct.
Yes. Dr. Rao, would you like to add something to this?
See,
Dr. Rao,
again,
sir?
yes, I think I'm unmuted.
Yes. You're audible, sir. Please.
Okay. The main thing is that, as Vipul has said, a complete transection requires surgical intervention. As long as a guide wire goes across, we can manage it. It all depends upon how long and how often you have to change the stent, because the stent is likely to get blocked. It will get cholangitis, and if you are using a, a non-metallic stent, you will have to remove it and replace it because of the occurrence of cholangitis. So that is an important point that as a surgeon, I will feel that probably surgery as a one step would help to overcome the problem of repeated ERCP and stent change and looking at it at a number of steps that we have to go through to dilate the stricture.
Thank you, sir. Thank you very much. Now, the take-home message would be beware of post-operative bile leaks. Early detection is the most important thing. Perform ERCP at the earliest, since this is a therapeutic procedure. And most of the lab cholecystectomy biliary leaks, they can be managed with ERCP. The next case, this is a bariatric case. A 38-year-old woman had arthritis, hypertension, and also she was operated for a laparoscopic gastric bypass. Patient had an ordinary post-operative course and she was discharged on the second post-operative day. She was readmitted on day 8 with abdominal pain and signs of leak. In this case further, the CT scan was done immediately and there was a leak at the anastomotic site. The patient was taken up for laparoscopy and the peritoneal toilet was, and at the same time, upper GI endoscopy was performed. This clearly revealed that the air bubbles are leaking from the rent and confirmed that there is a leak. Endoscopically further, this rent was stented. A fully covered stent was deployed and laparoscopically it was confirmed that there was no further leakage of the air bubbles. The patient was discharged. However, and a post-procedural CT was done. It didn't show any leakage. However, the patient continued to have symptomatic after 1 or 2 months, and he had a dysphagia. Initially, the stricture was dilated with CRE balloon. However, the patient continued to be symptomatic, and then this is the retroverted gastric pouch. And then for the stricture, the stricturoplasty was done with a needle tone. The stricture was lice. After the complete division of the septum, again, an esophageal stent was deployed to maintain the luminal continuity, and perhaps the endoscopist must have been afraid that there could be a small leak at the time of doing the cuts. And after this second stent, the patient recovered well. Now I hand over to Dr. Goel to take the discussion further.
Yeah, thank you, Dr. Bulgaonkar. So I think there are two issues about this. One is the issue of placing a stent at 1 week after the leak, because this is a low pressure leak from gastrogenostomy in a gastric bypass. So if the laparoscopy was done, which showed contaminated peritonitis, a good lavage and drains would have probably resulted would have the same results as putting a stent at 7 or 8 days after the primary surgery. So I would like to know from Vipul, would you like to comment on this? What in your experience is of putting a stent post bariatric leaks?
Raman, I think it's a very interesting case. As we saw on the laparoscopy image, the rent was very small.
Yes.
So if I would have intervened here, I would have probably put a Ovesco clip and closed the defect. There was one possibility.
Yeah.
Now, I have also seen stent-related complications. So what happens is that when there is no straight axis of the anastomosis because of the resection of the stomach part, what happens is the proximal end of the stent gets indented in the wall of the esophagus. And I have seen perforations because of stent somebody has placed earlier. And there was another problem to solve. So I personally reckon that now with better clips available, we can have this kind of small defects closed more effectively with such clips. So I would have tried that clip. However, there are some reports in international literature where they put clip and then they put a short stent just for a short period of time.
Yeah.
Just to tide over the crisis of leak and stabilize the clip and that keep that area open so that there is no regurgitation and the flow of the contents. So this is one thing I probably would do, that I'll put a Ovesco clip and put a short stent for a while and then go in, check the gastrography and take out the stent at the earliest.
Yeah. But in this case, we had a peritonitis and laparoscopy was definitely required.
Right.
Once the surgeon was inside and had a small leak,
correct,
putting a stitch and putting a mental patch on top would have served the same purpose instead of putting a whole stent.
You see, Raman, we all are very wise in retrospect, but we don't know the clinical course, how this leaks, this anastomotic leak, sometimes we all know can be notorious, and because of various reasons, just lavage and putting a patch perhaps would not have worked. So something should have, and I think that has been managed. But my question is about the stent. So stent alone has its own problems, which all surgeons should also understand, that it is not without problems that you place stent and you think that everything will be fine. So this is something which I would like to highlight to all the bariatric surgeons.
Dr. Bapaye, what about the stricture that happened afterwards? We saw the endoscopist dividing it with a knife. Would you be comfortable doing that? What is the possibility of perforation while doing this? Dr. Amol? Dr. Amol Bapaye, are you there? Okay, I think his audio is switched off. Dr. Krishna Rao?
Dr. Goel?
Yes?
Yeah.
Hello?
Yeah.
Anyway, I'll take a Yeah. So whenever a stricture of that nature is there, that it was a very short ring stricture. Now these ring strictures are very well managed by an incision kind of approach. And we've shown that there are several studies in literature now to show that Mercedes-Benz kind of a cut, three-pronged cut, and then dilatation of the stricture, either with a balloon or sometimes even a stent may be required depending on that. But usually even a balloon dilatation would suffice after that incision. And that really opens up the stricture very well. To follow up with the initial part of the discussion about the leak, I would definitely agree with Vipul in this matter that nowadays with full thickness clips being available, we are putting in stents less and less often because stents tend to seal the leak but need not be, it may not cause healing of the perforation. So a sealing may occur temporarily, but healing may not occur. And that we come to know only once you remove the stent after a few weeks. So by that time, the time is gone. So we prefer to put in clips and full thickness clips in that nature. And I will also agree with him on the point that, a combined endoscopy and lavage option, laparoscopic lavage option probably is better. The other thing we need to understand is that all tissues over here are very edematous, and because of that, whatever we do, it may be a stitch, it may be a clip, it may be an endoscopic stitch, none of us are ever going to be 100% sure that that modality is going to be useful and 100%, it is going to cause sealing of the leak. So that's something that we all need to understand that.
Yeah. Only one message for the surgeon who has done it, yes, they have done a good job and they came out winners, is that a feeding diagnostomy or a fracas tube, and they should always be put whenever we have a bariatric surgery and there's a leak.
Absolutely.
Dr. Bapaye said it may be a long course before the things heal, and nutrition is so important. So that's mandatory either way, either laparoscopic feeding diagnostomy or a nasodigital tube is essential. So Vipul, last comment, and then we move on to the next case.
Just a small technical inputs. When you said that during the needle knife stricturotomy, there was probably a small rent, and that's why they had to put a stent again. I would not use a bare needle knife in such strictures. There is a insulated tip, IT knife we call it, and if you use that kind of insulated tip knife, just for the knowledge of our colleagues who are doing aggressive, I'm sure Amol would also agree with me that an insulated tip would give you a much better control on the depth, and you're not accidentally injuring the stricture beyond point, which is not very easily seen in a lot of times. So just a technical input.
Great. Thank you, Vipul. Dr. Vijay, you can continue, please.
Thank you. So the take-home message in this case is, suspect the leak at earliest. CT scan should be done without any delay, and take the opinion of endoscopists because they are going to help you. The next case is a 62 years male underwent anterior resection for rectal cancer. On day 4, a CT scan was performed because there was a suspicion about the dehiscence. The dehiscence was confirmed on CT scan. Scopy was done and a perforation was observed. Now, Dr. Vipul, what is your line of action further?
Well, I feel that, as I mentioned earlier, that we are in a position now to even offer a full thickness colonic resection, early colon tumors with a device which allows you complete serosal closure. I would first assess the site and the extent of the perforation. And then, if possible, we would like to close this defect with the newly available, clips, which are the Ovesco clips, and we can possibly close this defect.
So this was the perforation, and the endoscopist has gone with the over-the-scope clip, and this perforation site was sucked in.
Yes, we can see that.
And after the full suction, The entire range was in the hub of the over the scope clip. The clip was fired. Contrast study was done immediately. You can see the clip there, and there was no leak.
So, Dr. Borgaonkar, I want to just add a little bit here.
Yes.
That because of this availability of these newer techniques and technologies, I think every surgeon who is doing routine endoscopy, even for their routine colonoscopy and other procedures, they should have all these clips available in their room.
Yes.
Because if you identify a small tear or a perforation, now gone are those days where you will, wait and then send a patient for a CT scan. And if you identify on the table, these are the clips which can be extremely useful and which can salvage a situation. So just an appeal to all surgeon endoscopists who are routinely doing endoscopic procedures to keep this in their armamentarium.
Yeah, Vipul, this is the real essence of this masterclass, I will say.
Yes.
This is all that we want to convey, that this is all within the armamentarium of a general surgeon, and all the surgeons should be aware of all these new technologies.
People, may I ask, what is the largest defect you can close with this OTSC clip? What is the largest diameter? I mean, if you see it is more than a centimeter defect in the colon, can you still cover the OTSC, or what is the limitation?
Yeah, the OTSC clip can take care of defects up to 10 to 11 millimeters. Amol, would you like to say something? Hello, Amol?
Yeah.
Yes.
That one we have is clip which can to 15 to 18 millimeters of defect. It depends on the tissues. So it should have become firm or hard. Then it's difficult to grasp all the edges into defend the cartridge, and the tissues are supple. Then you can even get even up to a 2% defect. You can probably close with a 16 millimeter clip. So it all depends on the timing of the procedure, rather than just the size of the defect. So all these things are important. And nowadays we also endosuture. So the size of the defect is no longer a concern, because even a 5 centimeter use
Thank you, Amol. Vijay, you have 2 more minutes to conclude the session. Thank you.
Can I just one point, Vijay? So Amol mentioned about Apollo's overstitch device, which you can have defect closed even up to 5 centimeters, if that's what you mentioned. So yes, you can need a specialized device like this if you need to close a large defect. But what we also have done is that what we do is we put circumferential clips at every maybe 2-3 millimeter, 4 millimeter distance around the, and first we put an endo loop and put clips all across the entire circumference, and like a purse string, then we close the defect. So there is another alternative, simpler way of dealing with, but then you need to have tissues which are soft and pliable, so that you can have a purse string suture, and then over this purse string suture, then we put a Ovesco clip and close the defect. So this is possible to do up to 2.5 centimeters. Yes, you can.
Thank you. Thank you very much. The take-home message in this case will be, the leaks should be suspected at the earliest post-operative period, and the corrective measures should be taken earlier. CT scan is one investigation that should be done at the earliest, because that is going to pick up the leak very early. The leaks can be managed endoscopically, and there are varieties of ways by which endoscopists can manage it, as you have heard just now. And the patients can sometimes have not one but multiple complications, but we can still take the help of endoscopies to tackle this. Thank you very much.
Thank you. Vijay, there was one question from the audience in the chat box. The question is for ERCP. When we do, he wanted to ensure that the patient's sepsis should be controlled, and also if there is any bilioma, image-guided drainage is precede the ERCP. ERCP should be preceded by these two. That's what you want to clarify. I say that is understandable. I think your case is a clear-cut case of a CBD stone at the distal end, so we went in straight for the ERCP. Okay, apart from that, it is nice. Do you have any more case to discuss?
No, I've finished. It is 4.
Thank you.
Yes.
Thank you. Thank you very much.
Thank you.
Thank you very much.
Thank you.
Thank you very much.
I think we have to thank Vijay and also our President Raman and all the faculties and expert panelists for a wonderful discussion of 4 interesting cases where the endoscopy came for the rescue. And I think we are now moving on to our next important session, that is endoscopy, laparoscopy interface. 3 master videos from our masters in this field, because at sometimes endoscopy and laparoscopy, like what it's shown here, like work as a tandem, either simultaneously, sequentially in various situations. To do this session, I request our moderator to join, people to stay back. Along with that, I think we are going to have Dr. Satish Mida from Ranchi and Dr. Pramod Sinde from Nasik to join. And we are going to have 3 interesting lectures. GB Rao might start later. So we request Professor Subhas Khanna to join to say about the importance of doing in managing a case of CBD stone and gallbladder stone. When you have a concomitant CBD stone, the challenge of doing a single stage lap pulley and ERCP. And after that, it will be followed by Dr. Roy on his control of laparoscopy assisted endoscopy for middle GI bleeding or a small bowel bleeding. Then we will have a GB Rao if he joins. Over to you, Subhas sir.
Hi, everybody. Good afternoon, my dear colleagues, faculty, and my dear moderators.
Good afternoon.
Good afternoon.
Yeah.
Good afternoon.
Can I have my screen shared? Just one.
Yeah, please.
Yeah. Well, I will be speaking on management of concomitant CBD and gallstone. All of us, we have seen the revolution of gallstone in the last 3 decades. But then, along with that, we keep getting, we know that about 5 to 18% of these gallstone patients have also concomitant CBD stone. As a surgeon, now when I say this, I say as a surgeon, we have been taking help of, most of the surgeons have been taking help of pre, intra, and post-operative endoscopy, and that's the topic of the discussion today. Now, when a surgeon takes such a case, he has to know that when there is a patient may be asymptomatic. When he takes up a case of gallstone, he must understand the patient may be asymptomatic. His liver function may be deranged or may even be normal, but then he has to always have a element of suspicion. We also know that 20% of these CBD gal may pass out spontaneously, but then what about the 80% of these cases? Now, what we do mostly is diagnose these cases preoperatively with an abdominal ultrasound. The ERCP is now obsolete as a diagnostic tool. It is only available as a therapeutic tool. The CT, yes, the sensitivity is 65 to about, if you use a contrast, maybe about 90% sensitivity there. MRCP is said to be one of the investigation of choice, whereas EUS in these cases is about 100% accurate. Now, coming back to the topic of today's discussion, the management option. What options we have as a surgeon in managing these cases? When we look at the option in a patient who comes to us with both GB and CBD calculi, ideally, the present management option is pre-op ERCP plus lap cholecystectomy. We also have an option of open CBD exploration. We have to look at the other options. Can I manage this patient on the single session? Well, to be very frank, I don't do it routinely, but when I saw some of my colleagues, particularly Ishamurthy, doing, I have got a nick of it and we have started doing, and we saw, when we look at the literature, we saw that compared to lap CVD exploration, a single session endoscopy retrieval of the stone with or without lap cholecystectomy is a very good option. Apart from that, not only endoscopy, even if you are a very good laparoscopic surgeon, you can do a cholecystectomy and you can also do a exploration. So now we have twin sessions. The problems with the twin session: you do an ERCP, you cause the inflammation of the callus triangle, you make the surgery difficult, and in high-risk patients, we have another problem. You need two anesthesia. At the same time, if you do not do within 48 to 72 hours, if you delay by more than 2 weeks, when we look at the literature, we see there are a lot of concomitant morbidities in this patient. They come back with recurrent stone, pancreatitis, and cholangitis again. So a single session approach should always be thought of and as an option. Look at what we want to do in single session. In single session, we can do ERCP followed by lap chole on the table in the same sitting in a hybrid OT, or we can also do a cholecystectomy followed by ERCP. Second option I have marked because this option seems to be better. The reason is when you have done an endoscopy, you have to use a FICS jejunal tube. You have to do a colonoscope to check out the gases, because sometimes in a difficult ERCP, there might be a lot of gastric distension of the bowel, causing difficulty in doing laparoscopic surgery. So supine position, we do a standard lap cholecystectomy followed by ERCP, even in supine position. Although most of the time, most of the endoscopists or endosurgeons prefer doing in broad, but supine position, it's quite good enough. At least when most of the pancreatic duct we do in supine position only. The one thing when you plan to do this is you have to have a very wide OTs, big spaces, and the one which I would like to say is most of the OTs nowadays, the equipment are on the pendants. So you have to have a movable trolley, and I think we all know those who are doing ERCP, we have to have a oxygen, anesthesia, suction, twin monitors, and a resuscitation trolley all the time. But what you was hinting that you have to have a movable cart so that you can take it back to the main operation theater. And there's a setup of such an OT which can be made hybrid with the main laparoscopy OT, because you can't have both the system at the same OT all the time, because most of the time we are very busy doing both the procedures. In single stage ERCP, the patient should not be septic, because that you cannot do. He should not be having deep jaundice, although arbitrarily we take 3 or 5 milligram of cerebrolidine as a cut mark, but then there is no literature evidence of what should be the cut mark in case you want to go for a single stage. CVD calculi should be few. If it is a large calculi, probably it would be better to go for a lap CVD exploration. If there are multiple large, probably I would prefer going for a spyglass cholangioscopy followed by lap cholecystectomy. But there should not be a stricture at the CVD. There's anatomic abnormality should not be there, and previous abdominal surgery. These cases, although it's a related contraindication, you can always go for a radiolysis or do a surgery. And as I said, availability of a hybrid OT when the cart can be taken to the main laparoscopy OT as and when required. As I said, we complete standard cholecystectomy with 4 ports, followed by ERCP in the same sitting. In case of difficulty, in case of a difficulty, a Rendo's technique can also be done. You can always leave hydrophilic guide wire through the cystic duct or through the ambulavator and take it out with a snare. That makes your job much more easier, and you are assured that you can complete ERCP later. It's a great advantage in a difficult papilla. There's a lot of literature available to support this view that one of the recent articles in the last month's JAMAs on meta-analysis of single stage versus 2 stage has clearly concluded that the results are almost similar and with equal amount of mortality and morbidity when we do a single stage or 2 stage procedure. But single stage, in one sense is advantageous, at least in some category of patients. I have a patient whom I will be doing 6 days tomorrow who needs a temporary pacing. So now imagine in a patient you do a ERCP first, and thereafter you again do a pacing, and thereafter you again do a pacing for doing a lateral cystectomy. So you are doing 3 procedures or 2 procedures with 2 temporary pacings. Steps of ERCP, I think this is known to most of the surgeons nowadays, but still for the young surgeons and students who must be attending, we go for a selective cannulation, sphincterotomy, or a balloon dilatation of the ampulla, depending on the size of the scalculus. And thereafter, mechanical lithotripsy practically is now obsolete with spyglass and cholangioscopy coming up. The ampulla can be cut with a pre-cut knife. We can do a fistulotomy, as I said, and we can also cannulate the pancreatic duct and go for a pre-cut sphincterotomy in case of a very difficult case. Almost all these patients we have done, those patients, very limited number which we have done, we nowadays go for a selective cannulation where we selectively cannulate the common bile duct and all the PT if you do not want to, and that's how there is less incidence of pancreatitis. In fact, in most of the difficult cases where you have already cannulated with a guide wire, you are not touching the pancreatic duct at all, and there is much less incidence of post-ERCP pancreatitis if you are doing in a single stage where you have already put a guide wire, a retrograde guide wire. Balloon sphincteroplasty we do in some difficult cases, or where there's a very flat papilla, or where the papilla is around the papilla there are multiple duodenal diverticuli. Remove the bile stone is standard the way we do in ERCP. We do the same technique here with lateral cystectomy in the same stage. You can see the film on the left side. This is in supine position, but here it's being done in the prone position, and that's why the scope is seen on the other side. If you are lucky, at times, if you do a very good sphincterotomy, this is a very bulging papilla which can be cut more than a normal, because and then if you're very lucky, you may be able to take out a giant calculus also in the same space while doing a lateral cystectomy, because you are prepared. If you have done an ERCP preoperatively, in such case, you can always go and do a lap CVD exploration, a single stage. And with a spyglass in our hand nowadays, in the single stage, you can also do a cholecystectomy followed by spy cholangioscopy and laser lithotripsy of all the stones. As I said, in Randall's technique, you can always cannulate from here, from the cystic duct, and take out the guide wire. With a snare, you can drag it out, and on the guide wire, you can again always go in and do a proper cannulation and sphincterotomy and ERCP later on. One thing which we have started doing now, a very, very recent development, is I would like to show an open surgery view, because right now I'm not having a endoscopy view, is on table laparoscopy and conventional surgery use of a spy camera, which is a slightly new thing. This was a patient where I was called by a junior colleague of mine, and this should be an eye-opener for us, where you can always use a spy cholangioscope. You can see the blue spy cholangioscope, which is being introduced into the common bile duct to a dilated cystic duct, a transcystic. This is the colleague who was not able to locate the common bile duct, and he invited me to help him, and from there we started make this beginning, and now we are using a spy cholangioscopy both in conventional surgery, FASGE we are doing, or in laparoscopy also. It's a wonderful view. This is an unedited video. I would just like to show. From there you can also go into the duodenum, and you can see the ampulla, and then you can see the calculus there. So this is a laparoscopic and conventional use of spy camera in which may be the future of single stage, single session lap and common bile duct exploration. Or managing both the CBD and the gallstone. You can see here in the And you can also see that these are the duodenal folds which are being seen here. So the spy camera can go retrogatorily from above into the duodenum, and then so this for the curiosity of those who would like to do this, I was sharing with you all. Single stage lab chole and ERCP patient selection we have already discussed. Procedure we have discussed, standard 4-port followed by ERCP with or without Rendo's guide wire through the guide wire placement. Benefits: single anesthesia, single stay, less mobility, less pancreatitis. Preoperative ERCP, there will be patients, particularly those patients where ERCP is going to be very, very difficult. I'm coming to that. Or those patients who might need a twin session therapy, and this is when patient has a severe biliary pancreatitis with a calculus impacted at the ampulla, or having septic cholangitis. So these are septic cases where there's no question of going for a single stage lap cholecystectomy and ERCP. These patients need immediate decompression. If you are lucky, you may be able to take out the stone. If not, then it's better to put a stent and come out in these cases. Single session. So now, as we discussed, two options: first lap chole, then ERCP. But do a lap, the better option than the second one. In the second one, do an ERCP followed by lap cholecystectomy. But you have to be very careful, because this is going to be very difficult in these cases with a lot of gas present in the stomach, duodenum, and the bowel. When you do ERCP on the table, the inflammation is in the Gallus triangle is less, fibrosis is less, and it makes the operation much more easier for us. I think this is what we have discussed, the Rendo's technique, where we take out the guide wire with the snare. The 5 or 6 difficult cases which needs a serious thought are large stones, 25 millimeter or more. Today, I think we can manage easily with on-table spyglass cholangioscopy and laser lithotripsy. Multiple intrahepatic stones used to be very, very difficult. Even we used to say hepatectomy. Now with spyglass cholangioscopy, most of these can be managed easily, both in the single session or twin session, whichever a surgeon is used to. Multiple trithepatic stones need multiple sittings of ERCP, and more than 3 ERCP sittings may cause lot of thickness and inflammation of the wall. So we may have to think of these cases in the single stage, so that we do not leave behind multiple trithepatic stone and go on doing post-lap chole endoscopic extraction repeatedly. CVD stricture is definitely a problem where ERCP may fail post-operatively, so this must be managed in the single sitting. Duodenal diverticulum, definitely a problem. You may end up with a perforation, so must be managed in the single session. Bildroth to Roux-en-Y operation, you are never sure that we'll be able to cannulate or not. So either go for an Endos technique now, or you go for a single session. It's better, do not take any chance in these cases. The message from me is beware of concomitant bile duct stone, as 5 to 18% of patients with gallstone have concomitant CVD stone. Twin stage management is the common approach. We all know, we all do it, but we can always give it with cholangioscopies coming. We can always give a thought and some of the cases to start with a single stage laparoscopic cholecystectomy with ERCP, which is always a feasible option, which is cost effective and also safe. I would like to end here with what Alfred Kusheri had said, that like the tablet mature that ended the age of dinosaurs, will there be some similar remedy discovered for calculus disease of biliary tract that would end the age of biliary surgery? He also says that if you cannot manage the common bile duct stone yourself, either by endoscopy means or by laparoscopy conventional means, you have no right to call yourself a hepatobiliary surgeon. Thank you, moderators, and thank you all the listeners who are attending, all the delegates who are attending this seminar or this webinar. Thank you.
Thank you, Professor Khanna, fondly known as the Rajesh Khanna of IAGS and Mr. Spyglass, henceforth you will be called, because really wondered to see so many options for people with a concomitant stone. I request the panelists Pramod Sinde, Satish to have some words before we will give a final say on this topic.
Thank you, Subhash, for your nice coverage of the whole topic. And things have changed in the last 20 or 30 years in the management. But still, most of the people would like to do the two procedures separately. Regarding your take on doing cholecystectomy followed by ERCP, Vipul is also there. There are always chances of failures in the ERCP, but now I know the chances are less, maybe less than 2 to 3% now, maybe even less in the experienced hands. So what do you do? Means those who are doing these concomitant procedures, have you landed in procedure that you have done a lap chole and the ERCP is now not successful? Then how to go about?
I think Vipul is going to comment on that first.
Well, I think, see, if you have a unit where a surgeon and an endoscopist or an endoscopic surgeon himself is doing both the procedures, then it makes a lot of logical sense to do this in one anesthesia and one sedation, because one anesthesia, because anyway, people who do procedure ERCP in supine position, this is the ideal way to go about. Having said that, the problem is that in the clinical setting, realistically, this is not available in most centers, in the sense that the endoscopists and the surgeons will have to collaborate and meet at one point and in the operating room. And those are some of the logistical challenges of most places. Subhash, you are a very lucky man to have everything under one roof. So I think in your situation, it is an ideal take. But I would prefer to do two-stage in any patient who has severe biliary symptoms, as you mentioned, or even a slight hint of some kind of infection. I think it is better we do stage procedure. Secondly, very important, I don't know how, whatever studies you mentioned, I don't know whether they are from United States, because a possibility is that you will probably, the insurance will not reimburse if you do it in one sitting. So this is a major challenge is going to happen if all work. So today, if I do an upper GI endoscopy, a colonoscopy, and perhaps an endosonography in one sedation, the insurance company tells me, Dr. Rathod will pay you for the first procedure, the second procedure will be 50%, and the third procedure will be 25%.
25%, yes.
Now, these are the serious professional realities which we'll have to face. Because
fully agreed.
Second
Fully
thing,
agreed.
Second thing that
yeah.
What about because chances of pancreatitis? This is also one of the which I also do both lap chole as well as ERCP, but still I have not taken up this challenge because I fear that some patients, maybe once in a year, one of my patients has pancreatitis. So if that lucky in patients becomes, because it's very difficult to handle. Secondly, mostly when I do a ERCP and then go for lap chole, most of these patients, maybe around 70 to 80% of these patients, they are difficult gallbladders because there is some sort of inflammation around it, and usually the duct is very wide and you have to tie those ducts. So these difficulties are always there. So I have not still ventured keeping these in mind, but still.
I would like to comment. I would like to comment here.
Yeah.
Whenever we do an ERCP, post ERCP cholecystectomy, it is always difficult because of our instrumentation, guide wire going into the cystic duct, basket touching the cystic duct, causing a inflammation there.
In 2 days,
so
it cannot happen because we do lap chole usually within 72 hours, 48 hours usually. I do ERCP today. We give a gap of 1 day and maybe around 36 hours. So 36 hours, these inflammations won't set up. These are usually fibrous, which are of long duration. These are not the flimsy adhesions. These are fibrous adhesions of few months.
Of course, yes. I won't strongly recommend right now because we have just started. We just thought, why not we start using spiral endoscope intraoperatively and see the results. I will not strongly recommend the standard 90-95% success you can get with pre-operative, pre-procedure ERCP followed by cholecystectomy after 48 or 72 hours, provided the patient is fit for cholecystectomy, is not septic and cholangitis. But then a food for thought, can we think about it, do a study, and in the next 1 or 2 years see the result? I feel the chance of pancreatic will be nil if we do same stage cholecystectomy with ERCP on the same stage, or ER extraction, because now here you are on the table, your ports are also already there. If you have any difficulty, rather than you touching the pancreatic duct and the pancreatic duct accidentally, you can always put a guide wire retrograde from above from through the cystic duct, and the guide wire will guide your sphincterotomy or your balloon. I feel the incidence, if we have to reduce the incidence of pancreatitis, maybe this is one way of thinking, one way of doing. Probably we will have to come up with a big literature data later on this.
Sure, sure.
Ishamurthy can comment here if there. Ishamurthy can comment, please.
Yeah. I think there is evidences mounting up now to say that single stage ERCP lap chole decreased incidence of post ERCP pancreatitis. That's been proved in several studies, but we need to critically analyze. I want the words of wisdom from Vipul. Before that, a final word from Pramod. Pramod, as a moderator, please come in.
Yeah, well, it was a very excellent talk, Dr. Subhash. What I wanted to, my take on this was, first of all, we should also have a look and evaluate during surgery if it is going to be a very difficult gallbladder where there's a very empyema gallbladder, difficult cholecystectomy, a subtotal cholecystectomy has been done, and a long procedure has been done, which itself is going to be open to complications, then maybe we also have to take a consent for not being able to do it simultaneously. So the case selection should be not very difficult gallbladders, more straightforward cases, simpler procedures where we could combine both the procedures. That is one. Secondly, if we are doing it simultaneously, that would mean that we have not yet clipped and divided the cystic duct, but because we want to keep that window of doing a rendezvous procedure by putting a guide wire through the cystic duct in case the ERCP becomes difficult in a supine position. So that means that we would have done most of the dissection, but not yet still clipped and divided the cystic duct, keeping that option of putting a guide wire through the cystic duct stump in case the ERCP specialist needs it. Otherwise, I believe that in well-selected cases, it is a wonderful option. And with CO2 coming in for endoscopy also, I think that it makes a lot of sense in selecting our cases well, taking the simpler gallbladders and not very packed CBDs, which are itself going to be difficult. These two procedures can be very well combined.
Thank you, thank you. I think we need to move on to the next case. We are timing.
Can I make a last comment?
Yes, Subhas.
The reason Ishamurthy gave me this topic and the reason we are discussing this topic, this is my concluding remark. This reason is surgeons have taken up therapeutic endoscopy in the recent past. So now it's a totally different scenario. The surgeon himself is doing therapeutic endoscopy. He himself is doing ERCP and he himself is doing laparoscopic. That's why we were never thinking about it, because the medical gastroenterologist was to be involved here, and which he will never, because the timings do not match with his timings. So probably this is the way in near future something is going to come up in this single session cholecystectomy and management of CBD calculi. Thank you. I think we can move on.
Yeah, thank you. I think we are moving. Thank you very much, Bas, and thank you all. I think you stay back, all of you, and we are going back to Roy Patrankar from Mumbai Gen Hospital to give his expertise on another very important topic as far as the surgeon's perspective. When we have upper GA bleeding, lower GA bleeding, may be easy to tackle, but always a challenge for anybody is a middle GA bleeding, what I call the obscure bleeding, somewhere in the small bowel. So he has challenging situations, and he is going to counter with the laparoscopic endoscopic interface in his own style. Over to Roy, please.
Thank you, Dr. I'm going to show you two very simple cases of small bowel bleed that we tackled with a combination of lap-assisted endoscopy. I bring greetings to you from Mumbai, and thank you, Dr. Ishwar, Dr. Ramen Goel, and IAGS for inviting me here. The first was a patient who was a 49-year-old gentleman, history of subacute intestinal obstruction, chronic colicky abdominal pain. His CRP was 22, ESR was 88. A colleague of mine from the western suburbs of Mumbai had given him 6 months of empirical AKT. His stool occult blood remained positive. His OGD colon were normal and a contrast enhanced endoscopy and otherwise. Capsule we didn't want to do because of his. We did to a diagnostic laparoscopy, and you will see what I find. As we put it, this is a 5 millimeter scope, hence the vision is slightly limited as compared to a tel. Most of these cases we do as daycare procedures. So the first thing we saw is a jejunal diverticulum, which, if you like, is a red herring. It won't be contributing to the problem. We go further down the jejunum. The CT scan had shown no dilated bowel, no lymph node, and no strictures. But as you carefully go down bowel, you can see this, what I call the creeping mesentery. Just at the tip of my forceps, you see the mesentery is creeping towards the anti-mesenteric border in some areas. I'll show you a little bit better, but just to show you what normal mesentery looks like, and this is particularly for the young surgeons, the residents in the periphery who are watching this, very commonly missed soft sign, as I call it, not a very typical stricture. But so we decided to do a small enterotomy, brought the loop out, flexible gastroscope down into the intestine, just beyond this, because we are strongly suspicious there's something going on there. Here I was moving towards the duodenum from the jejunum. You can see that all the mucosa is completely normal. The pylorus is seen from within. So this is a normal up to the pylorus, the pylorus. The directions started going towards. There were two areas of that we had seen. The scope is now put in the reverse direction. I have a 1 centimeter hole in the intestine, which my assistant is holding, going, and I start going down into the jejunum, and in a moment you see a soft stricture there. And this exactly corresponded to the area of the creeping fat. You also see ulceration at 12 o'clock and 6 o'clock position. This was then biopsied. Multiple biopsies were taken, which confirmed this to be Crohn's disease. So this patient had a fecal calprotectin, but his CRP was normal, and in our country, recurrent obstruction with that, many people tend to give empirical AKT. So clearly, he responded well to medical treatment and had no further follow-ups after 6 months. This patient with a large small bowel bleed was a 79-year-old elderly gentleman who was admitted under our medical oncologist with a massive hematochezia. He's a male breast, treatment 4 years ago, currently in remission. Also known hypertensive, diabetic, and ischemic heart disease with a PTCA done. He's on dual antiplatelets with aspirin and clopidogrel, presented in shock with a hemoglobin of 4.6. Iron studies obviously confirmed this to be iron deficiency anemia. After stabilizing the patient, we got a CT abdomen with a CT angio, which was reported normal, no obvious blush seen. Upper GI and lower GI was done the next morning after stabilization. The only thing we saw was a lot of blood in the terminal ileum. Because he remained unstable, we did a mesenteric angio, which was inconclusive. So at this point in time, doing a capsule wasn't much of use because they had massive hematochezia. We would have to repeat a mesenteric angio again after 12 hours in case he bled again. And our decision was, this was also the history of, this man had a history of poor intake for almost 2 months prior to this, with a significant weight loss. His ESR was in triple digits and LFT creat was normal. So we did a similar procedure like you saw me doing it earlier. We did a diagnostic laparoscopy, nothing seen in that. And then I'm putting my 190 series gastroscope towards the duodenum. We also wanted to put in a nasojejunal tube into this man. This is the pylorus seen from inside. So what we did was we asked the anesthetist to put a feeding tube, which I then dragged down into the jejunum because we wanted to give him feeds post-op. And then we decided to go the reverse direction. So the first step is to place the feeding tube, and as we go into the proximal ileum, you see these multiple small 2-3 millimeter sized nodules, which had not been seen either on a CT or a mesenteric angio. And this was, we saw a sign of active bleeding here, and on biopsy, this turned out to be a high-grade indeterminate type of lymphoma, which actually has a very poor prognosis. We did a embolization for this. So the key issue is a lot of surgeons in the periphery may not have availability of a double balloon. We are fortunate to have a capsule, a double balloon, a mesenteric angio, everything else, but there is also a major cost issue in many patients. I think you just need even an axion or a very basic gastroscope is good enough. You just need a laparoscopic surgeon with basic skill and a basic skill of doing upper GI endoscopy. You can use a normal upper GI endoscope, make a small enterotomy into the mid-small bowel and run your scope in both directions. This expertise is very likely to be available across the country. And I'm not saying it is the first line of treatment. Obviously, the first line of treatment is CT angio, mesenteric angio, and embolization. But in those patients where this is not available or it fails, then that would be a good option. Thank you very much.
Thank you, Roy. It was a very, very crisp and very useful presentation, Roy. As usual, I request people followed by Pramod and Satish to give their comments on this situations. How commonly you can use a simple endoscopy for rescuing from obscure middle GI or a small bowel bleed. People, what's your thoughts on this algorithm of managing middle GI bleed?
Yeah, Roy, congratulations. Good case. Just a quick question. On the first case, on a CT enteroclysis, there was no visible stricture.
So this patient had a CT with oral IV contrast, not a CT enteroclysis when he presented to us.
Okay, so this is very important for surgeons to know that when you are suspecting anything in the small bowel, you want to rule out a pathology, you need to have a proper CT enteroclysis. Important, even before you go for a capsule, and more importantly, before you go for a capsule. Because if there is an impending narrowing or a stricture somewhere like what Roy showed us, your capsule will precipitate an acute interstitial obstruction. So a CT enteroclysis is mandatory investigation. Given a choice, if you have all the investigative modalities available in a city or an urban center, the protocol would be, if no stricture, then do a capsule if cost is not an issue, identify, and then as a procedure, second stage procedure, do antegrade or retrograde single or double balloon enteroscopy. Now we have spiral and enteroscopy coming in, which allows you to see almost 95% of the small bowel in almost 85 to 90% of patients. So I also want to share with our young surgeons that capsule endoscopy has a miss rate of 15%. So in the best of the technologies available currently in the world, the miss rate of a lesion which had bled is about 15%. So therefore, I think what Roy mentioned and proposed, that in a non-urban center at a taluka or a district place, if you have a challenge that there is possibly a bleed from the small bowel, then this is a very good option where you have an enterotomy and use a gastroscope, both retrograde and antegrade, and examine the small bowel and solve the problem at the same time. Yes, it's a good idea.
Thank you.
Well presented, Dr. Roy. And recently we have not used this technique, but earlier, because now we have so many techniques available, but I have used in 2-3 cases and found it to be useful, and really it comes as a rescue, and we can diagnose, and mostly on the table treatment can also be done. So it's really a good technique, and it must be utilized whenever necessary.
Right. Yeah, it was a great presentation, and this brings us to this point that this intraoperative enteroscopy is especially useful in emergent situations. When a patient has come with a chronic GI bleed walking, obviously we have all the armamentarium including capsule, but when a patient presents as an emergency with GI bleed and where all the other modalities have failed to diagnose or treat that patient, in that situation, an intraoperative enteroscopy will not only be very valuable, but it will also be a life-saving for this particular patient.
Thank you. Thank you, Roy, for your excellent presentation. Thank you, all the faculties. I think we need to move on to the next important session. We are middle of our master class, the role of endotherapy for surgeons. I think this is the very important topic in the way we are now taking the surgeons from the diagnostic modality to therapeutic expertise by doing what we call the level 1 or level 2 procedures, which can be easily accomplished if you have undergo a proper training. To do that, I invite to start with the Dr. Sunil Papa to say how he tackled port hypertension with the variceal bleeding, followed by Dr. Govindraj to speak on the potential of SEM stenting for rescue in various GI disorders. To moderate the session, we have Dr. Navneetha Krishnan, our EC member before, and he is from Madurai, and also we have Gani Bhaskar Rao from GSL Medical College, and we have Sunil Kumar from Jamshedpur. Over to you, Sunil. Our president-elect is going to tell all his expertise on how he manages on upper GI bleeding. Sunil, we can't hear you. Sunil, I can't hear you.
His mic is on, but we cannot hear him.
Sunil, we can't hear you. Audio, we can see your slide sharing. Just to see the look at the audio, Sunil.
Hello.
Yeah, we can hear you now. We can hear you loud and clear. Yeah.
Thank you.
Yes, active variceal bleeding slide. We can see. Yeah.
Start from the first slide.
Yeah. I think it's better.
So thank you very much, Dr. Ishwar, for the invitation. I bring greetings from Ahmedabad. I've been listening for last 1.5 hours or so, very patiently. Beautiful discussion. My topic is to discuss about the management, the endotherapy for esophageal, gastric, and duodenal varices, which are one of the common causes of upper GI bleeding. The acute variceal bleeding can be potentially fatal in complication patient with liver cirrhosis or extrahepatic portal vein obstruction. About 50% of newly diagnosed liver cirrhosis patients have accompanying varices. About 7 to 8% of these patients develop new varices every year, or even existing varices become worsened. First bleeding occurs in 12% of the patient each year. So it's a very common situation we all come across. We are all aware about the symptomatology of the upper GI bleeding. Mostly it is hematemesis or melena or hematochezia. Patient requires emergency management, the management of shock, the IV fluids, etc. And first of all, we need to stabilize the patient before we can take the patient for endoscopy. The esophageal varices, the management is now esophageal variceal ligation or bending as it is called. About 50 years ago, we started with esophageal variceal sclerotherapy. But since last 20 years, we have moved on to variceal bending. Under direct visualization through an endoscope, we apply the rubber bands. These are the elastic bands applied on the esophageal varices. When the varices are bleeding, this procedure provides a mean of hemorrhage control. When it is not bleeding, it controls the varices and prevents the future hemorrhage. The indications are esophageal varices, the treatment of recurrent bleeding varices. It may be repeated every 2 to 4 weeks until all the varices are obliterated. On an average, 2 to 3 bending sessions may be required. What we need to do this procedure is a good upper GI endoscope, variceal bending device, bend ligator. If we are coming across fundal or gastric varices, then glue should always be there, and the needle and clip and loop, etc. Position of the patient, preferably left lateral position. And upper GI bleeding endotherapy should be done with anesthetist present, with sedation being given by the anesthetist, so that patient doesn't move while you are contemplating the endotherapy. So here is a case with a large esophageal varices, as you can see, with a history of recurrent upper GI bleeding. There are cherry red signs suggestive of recent upper GI bleeding. The NBI or FICS shows you the varices very clearly. So we apply the band mechanism at the tip of the endoscope and go inside again. We identify the mucosal G junction, pull out little bit, come at the mucosal G junction, and start with the most prominent esophageal varix, and then turn the scope clockwise or anti-clockwise, and one by one band ligate all the varices. The one band device has 6 or 7 bands attached to it depending on which company you are using. Most of the patients would require 2 band sittings if they are having such a large esophageal varices. So as you can see, it's a bloodless procedure, a very clean procedure. Another patient here, this patient previously had bands applied, so you could see the band ulcer. Again, we go ahead and keep applying the bands one by one on the esophageal varices. And one has to suck the varix inside the cap of the band mechanism and have a red glow sign and then apply the band. As you can see, it's a blood-led procedure, but one has to be very careful because sometimes it can lead to bleeding if there is a tear among the varix. Post-procedure, patient can have chest pain, dysphagia, which is short-lasting. Sometimes patient can develop esophageal obstruction due to edema or a stricture due to recurrent banding procedures. When do we do variceal glue injection? It's mainly for gastric varices, duodenal varices, and rectal varices. Again, we do it preferably under conscious sedation, mostly propofol sedation with anesthetist. For glue injection, we need to prepare entire endoscopic staff members. We need to give them protective glasses. Also, the patient should also be given protective glasses. The training should be given, and the acetone should be present in the endoscopy theater to prevent the clogging of the endoscope. We first do proper diagnostic upper GI scopy. We diagnose the condition, and we have to target the varix, decide the scope position for a particular varix. Glue needle required is 21 number. Prepare the needle outside, check in and out movement, flush the needle with distilled water. Injection, check the varix, scope and needle in position. The entry of the needle into the varix should be precise and sharp. Inject the glue followed by distilled water. Sometimes it is also called sandwich therapy because the cannula of the needle always have about 1 ml of distilled water, which goes first inside the varix, followed by the glue, followed by the another 1 to 2 ml of distilled water. Then wait for 20 seconds before withdrawing the needle, and multiple injections if required. Prevent the spillage of glue inside the scope and also outside. So here is a patient, as you can see on the retroversion of the scope, there are fundal and junctional varices. As you can see, so we feel them and identify the varix which needs to be injected. We check the position of the scope, position of the needle, that it is moving freely. Then bring out the needle. And this is an intravaricial injection. So go inside the varix and inject. As you can see, the varix is being inflated with the solution. Now we palpate it again and check which are the varices which have obliterated and which are the one which is not obliterated. So this is the area which will require another injection. Always change the needle, one glue needle for one injection only, then throw it away and take a new needle, check it, and then do the second injection like this. After the injection, keep the needle pressed, keep the cannula pressed for about 20 seconds and then withdraw. So there is no bleeding, as you can see. Another patient, these are large feeding vessels on both the sides. So here you decided to inject here, and we go inside the varix and then inject, as you can see. And then we palpate. And this is another needle and another injection. Sometimes it may happen that we get duodenal varices. This was a known case of liver cirrhosis, portal hypertension under my treatment for 10 to 15 years, presented with severe bleeding PR, hematochezia, and the reason was this large duodenal varix, as you can see in the second part. So we identified the varix. As you can see, the bleeding has stopped because of the terlipressin and other treatment which were given on admission. So then we did intravaricial injection of this varix. It is obliterated, but as you can see, there are multiple feeding vessels. So we palpate and check which of them are obliterated. And this one requires another injection. One and a half months later, we did this check endoscopy. And as you can see, the varices are completely obliterated. You will see the same area. There are no patent varices. These are only obliterated varix and some skin fold, mucosal folds. So I'm palpating. Palpation is very important when you are doing a recurrent injection or more than one injections. And all the varices are obliterated. This is a life-saving procedure, varicial glue injection. And once mastered, it gives excellent results. However, it can cause pulmonary embolism if too much of glue is injected and too fast. So one has to be very careful. It can cause a gastric ulcer or erosion formation due to glue eventration, which is mostly harmless. Sometimes it may cause bleeding. Sometimes you may come across a post-injection bleeding. So one has to, after doing the injection of the glue, one has to watch carefully that the needle entry has been sealed completely and it's not bleeding from there. If it starts bleeding from the needle entry, then you have to give another injection at the same place. To conclude, endotherapy for esophageal, gastric, and other varices is a life-saving modality. It has reduced mortality from variceal bleeding significantly. It has reduced the need for shunt surgery, and endoscopic surgeons learn the art and skills of endotherapy to control variceal bleeding. Thank you very much.
Thank you, Sunil. That was very wonderful, very nice 3 videos of all esophageal, fundic, and the duodenal varices. A good collection you showed, and I think it is one of the surgeons' armamentarium. I request Sunil Kumar and followed by that Gani Bhaskar to give their expert view on management of esophageal varices from surgeon's perspective. Over to Sunil, sir.
Yeah. Thank you very much. Very nice, Sunil, for your presentation.
Thank you.
This is variceal ligation, EVL, what we call, has come as a very important tool. So my own one comment and one question, that the objective or the end point of variceal ligation, as you rightly mentioned, is either obliteration or eradication of the varix. And 2 to 3 sittings, sometimes in our experience, it may take little more, 3 to 4 sittings also may be required. So we may not always achieve the eradication and obliteration, but what we try and achieve, because if it's a cirrhotic process, that process or pathology don't go down. So what we also try and achieve is the end point, either eradication and obliteration, which is the ideal. But if we can convert that grade 3 and grade 4 to grade 1, which is white and fibrous, where the chances of rebleed is less, that we would accept it. The other point is that there is still a role of endoscopic injection sclerotherapy for a residual varix or grade 1 or 2, which has the less propensity to bleed, but sometimes they do bleed. So as a surgeon and endoscopist, we should not be only conversant, but we should also continue to be practicing endoscopic sclerotherapy of polydocanol, which can be intravaricial, paravaricial, or hybrid. But well done. I'm very happy that you presented that. Thank you.
Yeah, thank you, Dr. Sunil Kumar. Regarding the need for eradication, in our institute, we have a protocol for very large esophageal varices. After the first procedure of variceal bending, we would do the repeat endoscopy after 2 weeks and see, and whatever residual varices are there, we will do bending again, and we will check after 3 weeks, and if there are no residual varices, then we would put the patient on regular follow-up. For the fundal varices, we would inject at least, if there are multiple varices, we would inject in at least 3 varices in the same episode, and then do check endoscopy after 2 weeks and gradually obliterate all the fundal varices with repeated glue injections. Once that is achieved, we'll put the patient in regular follow-up.
One more question, Sunil. Have you find any difference between banding or endotherapy for cirrhotics or patient who has got non-cirrhotic portal hypertension? Do their ability to withstand the banding treatment differ?
I think when you are doing upper GI endoscopy and you see that there are a lot of varices, whether cirrhotic or non-cirrhotic, if the patient is having multiple gastric varices, fundal varices, then it's always a good idea to start with the fundal varices treatment first. So we inject few of the fundal varices, come back and obliterate all the fundal varices first before we start doing bending of the esophageal varices. Second thing is we try to avoid doing glue injection of fundal varices and esophageal variceal bending in same sitting if that patient is going to require further glue injection sitting, because if you have done bending and if the patient starts bleeding from the injected or non-injected gastric varices, then you may have to go in through the esophagus which have already got the bends, and the chances of bleeding may increase. And if you obliterate the fundal varices first, then as you are aware, the flow of blood would be from below up, and so the size of the esophageal varices will also go down. Regarding the difference between cirrhotics and EHPVO, I think EHPVO patients sometimes present with larger varices as compared to the cirrhotics.
Thank you, Sunil. I request Gani Bhaskar Rao to unmute and give his comments. Whether we can, how we can train our surgeons in these therapeutic procedures. I'm sure you have a vast experience of various training models like symbionics and things. Is there any model available for teaching banding? I know for sclerotherapies we do have models, but I haven't seen one for the banding of varices. Do we have, or do we need to rely on the animal model? Because we should teach our students on the easy animal model, a porcine model, where they can very easily teach. And also, Sunil will agree, the learning curve is much shorter as far as the banding of esophageal varices is concerned.
Yeah, I think there is no learning curve as such. Once the surgeon or the endoscopist is good in doing upper GI endoscopy, for a surgeon it is much easier to learn this bending or glue injection procedure. And like you and me and all our colleagues, I don't think we learn on the animal models. We learned the art of endoscopy. We assisted the therapeutic procedures, and then we started doing under supervision. Similarly, a junior surgeon can also be trained like that. But I believe that this simulation companies are coming up with the procedures and the modules which can teach the junior surgeons how to do the glue injection or how to do variceal bending.
Thank you. Gandhi sir. Yes.
I'll come to the point that before that I have to ask you a question to Sunil.
Yeah.
When you're making the sclerotal injection or a banding, and you should make a stepladder pattern. Unless if you make a circumferential as a clockwise, you will get any time they can get sick. At that point, I think you have to insist on the things. One point. Second point, whatever it may be, a sense taking tube still is a gold standard. If any time uncontrolled bleeding, just put a tube, wait for a few hours or maybe one day, and immediately the patient can shift into the endoscopic room. At that time, with sclerotherapy, that is a good enough to save the patient. Some patients, we are unable to see the exact point because they flush with the blood. And even whatever the message you do, you can't see the exact bleeding. That one of the steps, and you should keep the things whenever needed. It can be maybe may not be used for 365 days, but at any time it may be useful.
Yes, sir. What I meant when I said clockwise bending is you go on withdrawing the scope and clockwise, and so you target the varices coming from inside out. And regarding this second thing, what you said regarding use of Sangstecken Blackmore tube, I used it last year before 18 years. So in last 18 years, it has not been required. It is good to have it in your endoscopy theater, but with the availability of somatostatin, octreotide, and terlipressin, most of this bleeding can be at least partially controlled with these medicines. And by the time we go in with endoscopy, you will see that the bleeding has stopped.
I agree with Sunil. I think last 12 years I haven't used the Sangstecken. It is still in the demo piece, still in my thing. It is mostly IV bolus terlipressin is quite effective.
Yeah.
And then if you are having a competent endoscopist, I am sure that is the way to go. And there are some extreme cases where we may have to consider even deploying a covered stent or consider them for TIPS procedure. So we should not think that only that is endoscopic banding is a solution. There are other options available. 2 times if you do, if the patient continue to bleed, failure after banding is one situation where radiologist might come for a rescue. What's your comment on that, Sunil?
Yeah, TIPS is very important for refractory facial bleeding, refractory ascites. But I think mostly 99% of the time we are able to control the variceal bleeding endoscopically. And it is not required that in emergency you have to send the patient for TIPS for the variceal bleeding. But if the patient keeps continuously coming back for the variceal bleeding, and there are new lots of varices every now and then you can send the patient for TIPS, or there is refractory ascites. Regarding putting a covered stent, I think it is still being under clinical trial, and not many institutes are routinely using it. But it is a new option which can be utilized sometimes.
Thank you. Thank you, Sunil. I think that
about your question about simulator.
Yeah.
And, I think some of the interventional procedures there in simulator, still the banding still not yet come, and there is a bleeding ulcer. There is doing a sclerotherapy, it has come. I think still yet to come, and lot of things can be done in future.
So, Dr. Ganibhaskar Rao, we can include these simulation companies into our courses or masterclass, and we can help them develop this variceal bending module.
Definitely, we'll advise them. We'll send a letter to them. Let them come. You work it out.
Thank you, Sunil. I think we'll move on to the next. Dr. Govindraj, our Vice President of South Zone, convener of endoscopy, is there to present on the potential of SEM stenting in various GI disorders. Govindraj, unmute yourself, share your screen. We are waiting for you. Govindraj? In the meantime, any comments from Professor Subhash Khanna, Satyapriya regarding the endoscopic management of portal hypertension? Like portal congestive gastropathy, that's the one area which is not covered by the, what is the role of APC? Satyapriya, what's your comment on that?
Yes, I feel portal congestive gastropathy is one of the silent cause of the causing anemia, because it's very little amount it goes, and without any breach of mucosa sometimes the little amount of blood goes out, and many of the cases anemia, we have seen that there is no ulcer. Ulcer is another important coincidence with the portal hypertension because of the mucosal problem. And we have not found out any esophageal, any gastric, any duodenal varices, and portal gastropathy is one of the cause. So I have actually used 2 of my APC cases over the very same patchy areas, and which have given me results. But I cannot say exactly as a golden rule, but that also can be taken care of.
Thank you. Thank you. Govindra, you can share the screen while we are waiting for Subhash Khanna to give some idea about the management of upper GI bleeding, his thoughts on that. Unmute yourself, sir.
APC is a wonderful tool to manage patients with gastropathy, particularly those with Graves' disease, or with pre-pyloric multiple erosions, and I think one has to know this and have to have a knowledge of organ plasma coagulation, because there are instances when you are going to need it in your cases.
Radiation proctitis is the one potential place where we can use that. I'm sure
One comment, if you allow, just 120-second comment.
Yes,
APC I have used in 50 cases, sir. Already we have sent for publication in cases of Barrett's. More than 2 centimeter Barrett's, I am doing the APC and also following up them at 6 weeks and 8 weeks and giving a fantastic results. That's another just thing.
Thank you. Thank you. Over to Govindraj. Your slides are seen. I can hear you also. Please carry on. Yeah.
Good evening, everybody. And it's wonderful to meet back again in this IAGS webinar platform of endoscopy. And my first, my namaskaram to my guru, Dr. BKR. I just want to thank him for all what he has made me do all this therapeutic endoscopy. And to start with this, and I'm very happy to share with all of you my experience and how it can be done nowadays by the surgeons for SEM stenting in GI disorders. My thanks to our president and our secretary and our treasurer. And what is self-expandable metallic stent? I'm going to just give you a short preview on this. These are stents which are made up of a material called nitinol, and they extend from 6 to 19 millimeters. There are various companies which manufacture these stents, and among those are the Cook, the Microvasive, the Niti, and a lot of other companies. Each company names their stent in a different way. Valflex, Evolution, Ultraflex, Alimax, Niti, it's different way they are named the stents. And these are the different types of stents which you are seeing here. And in this, if you exactly look into that, on the top blue, you can see that the middle portion is the covered portion. And generally, we prefer to have a covered stent nowadays. Initially, it was all uncovered. Because of the ingrowth that is coming now, it has become totally a covered stent. And this is the stent which I am showing now is in a case of a malignant esophageal stricture. The commonest cause for where you are using a self-expandable metallic stent in an upper GI is a malignancy of the esophagus. When the patient has a complete dysphagia, this is one of the commonest indication where you do a metallic stenting. Here you can see in this image a nice metallic stent that is, the stenting is in progression. You can see the stent completely expanding. And there are markers which you see here. These are the markers which are kept to identify the GE junction and the cricopharynx. And this is the stent which has expanded, how the stent exactly it looks. Usually, immediately after the stent expansion, you don't try to immediately poke in the endoscope because you need at least 24 hours for the stent to completely expand, and then you can push in the endoscope. And there is a new stent called the conio stent. This comes from a company called Niti from South Korea. This stent is basically used for strictures which are present very close to the cricopharynx. The initial guideline was when the stricture is around 5 centimeters below the cricopharynx, you can easily apply a stent. With this help of this conio stent, we can apply a stent even when the stricture is around 2 centimeters below the cricopharynx. That is the important thing which I want to express here. And these are the various types of stents and how each stent acts. See, when you look at it in the fully covered stent, fully uncovered, partially covered, then plastic stent and biodegradable stent. And these biodegradable stents, now they are not much happening. It is still in the process of development. And this plastic stents, SEPs, that is self-expandable plastic stent, which came into vogue and finally disappeared because of the high migration rates. And the fully covered or the partially covered stents are now stents which are completely dominant today's endoscopic world. And this efficacy of the stents, if you talk about, they improve the oral take in 95% of the patient, and particularly in tracheoesophageal fistula, it gives 70 to 100% success rate, because particularly malignancy tracheoesophageal fistula surgery is not a first option. Stenting is the first option. And there few complications can happen, either intra-procedural, post-procedure, or delayed complications. Intra-procedural complications are malposition, aspiration. That's very important. You should have a very good anesthetist who can take care of aspiration when it happens. You should be very meticulous. So most of the stenting are done under intubated condition. Usually, preferably, we do it under TIVA, that is total intravenous anesthesia. But when the stenting is going to be in the lower esophagus, I would generally ask my anesthetist to do one intubation, because to prevent aspiration, because stomach can be full. Once you dilate it, sudden gush of reflex will be there. You can aspirate. And perforation, that's important complication. The treatment of perforation is also going to be again stenting. And bleeding. Bleeding, most of the time, you can put a balloon and control the bleeding as a tamponade effect. Or you can put in a stent. Into a stent, you put a balloon and inflate the balloon and to cause a tamponade effect. The post-procedural complications are chest pain, foreign body sensation, and tracheal compression. Few cases we have had tracheal compression. In those cases, when there's a large fistula, the tracheal compression happens, patient goes in for a stridor, and few cases I have done a tracheal stenting to compensate for the deviation into the trachea from the esophageal stent. Delayed complications are stent migration, tracheoesophageal fistula, which happens because of the original stent. And there again, stent, again, you have to put in a stent into a stent. Bronchoesophageal fistula, same, you have to put in a stent into a stent, and you have to put another stent there in the trachea or in the bronchus. Stent occlusion. Stent occlusion happens particularly if you use an uncovered portion in the both the flare, in the upper flare or the lower flare. In those cases, we nowadays use APC, organ plasma coagulation, to completely luminize that area. Initially, we are using NDR laser. And this is a malignant tracheoesophageal. You can see a nice tracheoesophageal fistula on the right side in the 3 o'clock position, and that's the fistula there. And once the fistula is identified, stenting is the option. Here you can see I put in a completely covered stent, and you can see that stent has completely covered the tracheoesophageal fistula. And here there is the tracheoesophageal fistula. Again, it's a huge tracheoesophageal fistula. You can see on the left side top image, it's more than 5, 6, 7 centimeter tracheoesophageal fistula. This is the case where I had put in a tracheal, the esophageal stent. The stent almost deviated into the trachea. You can see the nice image there. I'm putting the scope into the trachea also. You can see esophageal scopes going to the trachea. Then what I did, there was a stricture in the trachea. So I dilated the stricture on the right image. You can see APC dilation is being done. And the lower image, you can see there is a tracheal stent and a esophageal stent. Here I am putting a esophageal stent. Esophageal stent migrated into the trachea. So I had to compensate by using a tracheal stent. You can see on the right top image, I have put in a tracheal stent there. So these are very rare conditions where you have to do double stenting there. And this really saves the life of the image of the patient. And the patient lived for almost 3.5 to 4 months after the stenting. And here is one late complication which happens when the patient overlives the expected lifespan. What happens is a tracheal esophageal fistula has been formed because of the complication of the stent. What we do here is another esophageal stent into the stent so that the fistula is completely obstructed. And another complication, what I said, is stent migration. Nowadays, stent migration has become very less. If a stent is migrated, the point which I have to tell most of the people is, you keep the stent introducer with you. You can re-pull the migrated stent. Here you can see I put in already a peg there. You can see the peg there. I can pull the stent and reintroduce the same stent into the same patient. But the chance of migration is going to be very high in those patients. And so ideally is a peg can be inserted for these patients. Here I am introducing the same stent. You can see that I am reintroducing the same stent. You can pull it up using a snare and reintroduce it in the same position. Next point, gastroduodenal stents. Malignant obstruction, malignant goo, gastroduodenal obstruction. The initial, as a surgeon, what we all used to do was gastrojejunectomy. Now there is another option that gastroduodenal stents can be done. And types of stents are, again, I would say covered stent and uncovered stents. Particularly in this area, I would say covered stents is not less preferable because you can obstruct the ampulla of Vater, the stents becomes longer. And these are the types of stents. These are called the D stents. These stents are made from a company called MITI. They are very good. And they are also made from a company called Boston Scientific. And these are the uncovered stents which we use here in the gastroduodenal area. And most of the gastroduodenal stents are through the scope stents. That is, you need to have a wide bore biopsy channel. You need to have a therapeutic upper GI scope to put in a gastroduodenal stent. Either it can be a wall flex from Boston Scientific, or an evolution stent from Cook, or a NITI stent from Taiwan Medical. These are the types of stents which you use. Success rate is almost 80% here. And here is a SEM stent which I am doing for a gastroesophageal junction. Gastroesophageal obstruction, you can see that it is the obstruction. Now I am deploying the stent. You can see nicely that the stent is getting deployed in the second part of the duodenum. And as I pull the scope out from the second part, it comes to the first part, and then I'm coming into the pyloric area. You can see now the stent has opened up in the pyloric area. I'm trying to put it in the scope and see that. The stent has completely opened, and there will not be any obstruction of the biliary tree also in this. And some adverse effects of these stents are the pre-procedural stent. Again, the same in the gastroduodenal, whatever I said in the esophagus, most of the complications are repetition here. And the next topic is leaks. Post-surgical leaks. There has been a very good development in this post-surgical leak. Beta stents are one of the stents which have completely revolutionized where you are treating the post-surgical leak. If you are identifying a post-surgical leak, immediately you can put a clip there and try to close that area, or do a suturing using an Apollo suturing technique. If not, if the leak is identified at least 3 to 4 days, there is a lot of edema around the area, then these stents come into rescue, the beta stents or the ELA stent from the Essex company. And these, here you can see in the image here, you can see nicely, the left image, it's a patient who was referred to me after a leak there, particularly for a upper esophageal malignant surgery. And as I put in the scope, I could see in the lower end of the esophagus, I was able to see it was a more of a proximal gastric malignancy where they're done. You can see nicely a fistula there. On the left side, I'm entering into the fistula, and on the main codes, you can see the gastrojejunal anastomotic site. Esophago-jejunal anastomotic site, I can see. And this is the area where the anastomotic site is there. On the left is the fistula. When you get into the right image, that is the day when I planned the stenting. When I get into the right image, you can see into the fistula tract is formed as almost like a diverticulum. This is almost 5 to 6 days after the surgery was done. The patient was referred. It was formed a diverticulum. Inside the diverticulum, there was a small opening which is connecting to one of the smaller intestines there. You can see I'm entering into the small hole in the diverticulum, which was apparently entering into the distal part of the small bowel. You can see, wait and see. This is a distal part of the small bowel. So what has happened? It has formed a fistula from the esophagus into the diverticulum, which is entering ultimately into the jejunum. So what I did was, we did a beta stent here and the patient was sent home. 3 months later, I called back the patient, and the patient, after I removed the stent, and after I removed the stent, you can see nicely the image coming up on your screen. The stent, the fistula tract has almost disappeared. It was millimeter in size. Previously, it was almost centimeter in size. Now you can see the fistula tract is almost less than 3 to 4 millimeter in size on the left side. So it is wonderfully worked. The patient is absolutely fine now. And indications for colonic stenting. The extracolonic pelvic tumors are producing the obstruction there. Their colonic stents are used. Or fistulas where there is a malignancy which is an inoperable tumor, again stenting is used. Or the third option. The third option comes into the major focus now, because when the patient has an obstruction, instead of doing an ostomy, you do an interim stenting, completely evacuate the proximal obstructed bowel, and then remove all the obstructed bowel, and all the dilated bowel gets decompressed. Then do a proper surgery, and at a later date. This is where the role of the interim stenting comes. And I am told what are the contraindications there. If it is the growth is less than 5 centimeters from the anal verge, you cannot do a stenting there. and or if the patient is or none of the MAP therapies, the high perforation rate is there, so we cannot use that. Coagulation disorders or abdominal abscesses, it is very difficult to do a colonic stenting. Particularly, these stents are either covered or uncovered stents, and all these stents are through the scope stents. That is, through the scope, either a wall flex or a nitty or the Cook stent. Either one of these stents can be used. Here you can see a growth there. It's a rectal stricture, and what I'm doing is I'm placing positions here. It's a rectosigmoid stricture here. I'm deploying a stent in the rectosigmoid stricture here, and the patient was completely decompressed. And after 2 to 3 weeks, the patient was taken up for a definitive surgery. This is what done to avoid a colostomy. And this completely saves the patient of a colostomy. Most of the patient would agree for this kind of an interim procedure. And the complications of colonic stents are synchronous malignancy. You have two malignancies in different patients. It becomes very difficult to stent, and probably incorrect technique can cause perforation. Stent migration is very common when the growth is very low in the rectal space, or fecal impaction can happen if the patient has a very high degree of constipation. And another stenting which everybody has already told, but just to complete it, SEM stenting in biliary tree. Here I am putting up an proximal biliary. That's a clad skin tumor where I am putting in a stent here at the proximal part of the hepatic duct. There is a malignancy. I have already put in a guide wire into the proximal biliary tree. You can see nice proximal biliary tree, and the intrahepatic biliary tree is completely dilated. And after that, I dilated this system using graded dilators. Once I dilated to 9 French, then I put in and here I have put in a Cook stent, which is a Cook stent. You can see nicely the stent is getting completely deployed. You can see the stent there, which you can see a nice waist in the stent here. You can see a nice waist in the stent. That is the stricture area where the clad skin tumor is there. And the next thing is a complete stent, which the previous stent will not be seen in the ampulla. And this stent is a case of a lower biliary malignant stricture where the stent was placed, and you can see that nicely the stent open up, and the stent will be seen into the ampulla. And these two types of stenting are all previously done, and now I'm showing the stents are already done. Usually these stents are done when the patient has a inoperable malignancy, particularly a biliary stricture, and where I want to show these. Here you can see nicely the stent is going to open up, and the stent is opening up. Once the stent opened up, and I can see that the lower portion, it will open up. You can see the stent is now opening and coming towards the ampulla there. And this is going to be my last slide. I'm going to complete now. And once the stent opens up, you can see it in the ampulla. You can see nicely the stent in the ampulla. That's beautiful. Yes.
Thank you.
Thank you very much. Thank you.
Thank you, Govindraj. That was very nice. You took us a path from esophagus through the whole GI tree, and also you extended your indication to biliary tree. It's very wonderful to see. Very nice videos. Gani Bhaskar and Sunil, any comments? Anything you want to add before we move on to the next chapter? Stop sharing. Govindraj, stop sharing your screen. Govindraj, stop sharing your screen.
Yeah.
Please stop sharing your screen.
Yeah, doing it.
Yeah, thank you.
Fantastic work, Govindraj. And
yes,
you enlightened everything and what to do, what not to do.
Thank you, sir. Thank you.
And then Govindraj, as usual, my only question, have you had any experience of esophageal stenting? Because esophageal stenting usually for tracheoesophageal fistula or malignant esophageal stricture. But any experience on corrosive, refractory, benign esophageal stricture?
No, we don't do for benign esophageal stricture, because that's what I said. The SEPs, when the SEPs, self-expandable plastic stents came, I started doing for the benign esophageal stricture. The migration rate was almost 60 to 80%. There is no point in doing. Then the company itself stopped the SEPs, plastic stents. So we have not started doing for the benign stricture. But now there have been instances from the company called Niti, where they have devised same nitinol stent where you can use for a benign stricture. But only advice the company says is the stent must be at least displaced every 3 weeks to 6 weeks, because there should not be any overgrowth. But I have not tried it at all. And now the biodegradable stents are also coming into work, particularly for these kind of corrosive strictures.
Thank you.
Okay,
Thank you,
thank you.
Govindaraj.
Thank you.
I think Sayan is ready to take us to the session 4.
Yes, thank you very much. Thank you.
Thank you.
Thank you, Ishwarmati. We
Thank
are
you.
having a wonderful session. Thanks to Govindaraj. I learned a lot about stents. Now, for the next session, I would like to invite Dr. Satyapriya Desarkar and Dr. T. Shivakumar. Satyapriya is the honorary treasurer of IAGS, and Shiva is our friend, and he is an EC member of IAGS. Shiva and Satyapriya, over to you to moderate the next session.
Satyapriya, Shiva, Sayanda, can you see my slides?
Yes, we can see. Please go on.
Yeah, thank you. Thank you. Good evening, friends. I think we are nearly 2 hours into this endoscopy masterclass. This particular session of about 25 minutes is mainly dedicated to the budding endoscopic surgeons who wants to know the basics. So I call it a back to basics on 2 important videos, each about 8 minutes. One, cleaning and disinfection of flexible endoscopy, and the other 2 is the foreign body removal, the tips for the beginners. I'm glad to have Satyapriya with me, and also Siva, and also all other expertise to give the comment at the end of this video. We all know when we call the laparoscopy as a critical equipment which goes to the sterile peritoneal cavity, the endoscopy can be classified as far as the spalting is concerned as a semi-critical. That means there is a mucous membrane preventing any infection, but still it needs some degree of high-level disinfection to safeguard the patient and also safeguard the equipment and yourself. So to protect everybody, we should have a system which is reliable, safe, and also most important, cost-effective. So we have a 5-step simple process of disinfecting the scope after every diagnostic or therapeutic endoscopy. What I call, as soon as you finish a case, you take the scope and do a decontamination procedure called a pre-cleaning. Then you do a test which is seldom done in everybody's hand. I want to stress it, the important, that is a leak test. A leak test is very important. Whenever you do an anastomosis, you do a leak test, don't you? Similarly, here also is an important element which we overlook, but we should not underestimate, because you are making an expensive mistake otherwise. The third step is you need to do a good flushing and brushing both inside out to get a good cleaning, because cleaning, decreasing the bio burden is the most important thing before disinfection. Once the disinfection is done, the job is to rinse it, dry it, either to store it in a cabinet well ventilated or take it to the next case. So as I said, we need to have a sufficient length of the brush and also sufficient quantity of sterile water to do this, because an endoscopy is like a baby. It is very delicate. You need to make sure that it is handled properly. And as I said earlier, the bio burden is minimized longer you spend. Minimum 5 minutes of cleaning with a brush is a must. Then only you should think about this. If you are not able to clean properly, you may have the option of either using this ultrasonic cleaner, especially for all these instruments, and also you can use some enzymatic detergents to facilitate a better cleaning process. Once you've done that, there are some specialized trays available like this. You please invest on this thing, because you were already invested on a very expensive endoscopy. Put them and keep the disinfection in the dwelling time prescribed. Even though one wish to have something like this shown here, like an automated washer and disinfector, it is not everybody's job. Not everybody can acquire this expensive stuff because the cost is a barrier. But if it is there, especially era like COVID era here, we are always worried about the infection transmission, because infection can happen not only during the endoscopy, but also during the process of disinfection. So this is actually not a luxury, but a necessity if you have it, an automated washer cum disinfector. But let us go on to the common things wherein 80 to 85% of you and me will be using is a manual disinfection, either using a Cidex 2.4% or parasitic acid. Parasitic acid is not widely available now, so we confine ourselves to Cidex, various types of Cidex available. The dwelling time is usually around 20 minutes, but you should be very careful to know that shelf life is only 2 weeks. Gas plasma sterilization is a very in thing for sterilizing endoscopic equipment. because heat sensitive items like flexible endoscopy can be sterilized by 30 minutes if you have high volume center. But let us go on to see how we sterilize, handle the instrument, see that my nurse how she is holding single hand, both hands safely, the endoscopy, and also a well ventilated cabinet where vertically you store. Don't store. The suitcase you buy the day one of your endoscopy is never should be used. If you keep it inside the suitcase, because of the moisture and the darkness, there is going to be contamination with the Pseudomonas infection. So you should be very careful to keep it in a well ventilated, mosquito net covered cabinet. Let us go and see this video for the next 7 minutes or so.
The scope is just out of the patient's oral cavity, but still connected to the machine, you imagine, and it is having some dirt, for example, blood-stained saliva on the surface. So you do an important procedure that is called a pre-cleaning. Just to clean the outer with a gauze piece to stop it, and then throw it away, and then you do 2 or 3 times. Then you have some antiseptic lotion like a Savlon or anything, especially this part, because this is called simple decontamination. This is not a disinfection. Once you have done that, the next important thing is you go and have a basin where you just start sucking. When you start sucking, then all the fluid, at least 200-300 fluid will go in and clean the channel also inside. So outside, inside, gross decontamination, that is step number 1. Step number 2 is you watch what I'm doing it here. Just for this demonstration, I have taken you another scope here. This scope is actually immersed inside. Okay, that is, once you've done that, still the scope is connected, but now connected with a special equipment to do a test called leak test. You may wonder what is leak test. I never done it, but this is the reason why we are doing it here, this particular thing. So leak tester is the one which ensures there is no micro perforation within the scope. For that, what we have done is, see, for example, here we have attached to the side of the scope here, there is a special, each company has a various ways of doing, and the principle is same. What is the principle? You have a machine which puts the air under pressure. Here the air is supplied by the same air feeder from the machine. When you switch it on, it goes and it insufflates the whole scope. The scope is now like a cycle tire, it's insufflated, and you immerse it inside. And when you put the air, if there is a micro perforation, what you see in the cycle tire or a tube tire, you will see bubbles come. Bubbles should not come. If bubbles are here, that should be an expensive mistake, because if there is a bubbles here, water can go inside, cause all the electronics on the channels, processor can damage, expensive damage. So you should feel, you have to feel, cry for this problem. So bubbles here, tears here, that's what I used to say. So we just put the machine on, it is on now, and look at this, it is now pressurized. But still, I don't see a bubble, good, but don't stop with that. These are the wheels here, you carefully see. These wheels, you just go, rotate the big wheel, rotate the small wheel, so that you stress the lower end such a way, even a small thing, the rubber is stretched, because when you do this way, so whenever you do one stretching on either side, the bubbles might come. So even after turning the wheel, putting into acute tension, there is no extravasation of air, there is no then air insufflation test, there is no leak. That is good. Then only you should go for the next stage, and that is brush, brushing and brushing. That is, you need to clean inside. So for that, what you need is a brush that is going to clean the inside. So there are 2 sides to the endoscopy. One, of course, I'm going to show is the access channel. See, through the access channel, if I go here, it will come out here, and as I retreat, I just take, see, you see what I'm doing here. So you have to see in the to and fro movements, to and fro movements, to and fro movements like that, and slowly withdraw so that the whole channel from the tip of the scope to the access channel is cleaned nicely, because that is the area all the blood stained proteinous material is there. And then you take this thing, but still it is not over, because there is another part, that is umbilical cord, which goes to the equipment, that has to be cleaned. So the superior button, you take it out, through which you have to pass this, and it will reach inside through the umbilical cord. In order to show that only, now we have disconnected the instrument for you to see, because this instrument is going to the mother, that is there, the processor, and at that end through the umbilical cord actually it is going. This is equally important. Don't just keep on cleaning only the insertion section. Equally important is the umbilical cord, because it has all the tubes going and to the final destination, to the processor. So you go in there until you see it is the very end. See, you can see it coming out the other end. So that means it is coming okay. Then withdraw it, like what I said before, to and fro movement, to and fro movement, to and fro, like that. You keep on cleaning, you take your time. If you hold it here, for example, it will buckle. If you hold it very close, it will be very effective. Without buckling, you do it like this. See, this is the way you have to clean. And you teach your staffs or make them learn this technique from the technical people who are coming from the company from which you bought the scope, so that they know the better, because the longevity of the scope depends upon how good you are cleaning. It should be as new as ever, and also it should be kept once it's dried in a very ventilated cupboard. So all those things are very, very important. Those things only we discussed in the earlier slides in the background. So you just do that way. Then if this is brushing, then again it is not enough. You have to flush the interior of this to have something like a bladder syringe, both through the access channel and also through this infiltrate. Now once you've done that, wipe the whole thing, then you immerse in the Sidex. So for that we need another tray that I'll show you in a minute. So this is actually a Sidex 2.4. You can use Sidex 2.4 or Sidex OPA or paracetic acid. Any of these things, depending upon what you use, the time you have to keep it inside varies. For example, the Sidex what we have here is about 20 minutes. You have to patiently wait. If you have too many patients, you have to have many scopes so that you have a circulation of the cases in such a way. If you are paracetic acid, it is about 10 minutes.
Internal wound. Short video while I explain. So this is the dilator which is introduced, and the dilator part is very, very important so that we don't cause any injury to the mucosa inside. After the dilator is very well introduced, then attach the dilator to the system.
Some background noise is coming. Kritika?
Yeah, sometimes it happens in Zoom. Other programs also they come in between.
That's what happening. This is what happening.
Satyapriya,
Satyapriya, would you like to add your comments before I go for the Sivakumar? Thanks for joining. Regarding the cleaning and disinfection.
4 or 5 areas.
Yeah, there is one more.
You have depicted. Thanks a lot. 100 times.
Once the speculum is rightly
which you have shown each and every point, and leak test is a very, very important. Everyone should know. When you buy from the company, you should know how to do a leak test. I have made it mandatory in both of my hospitals. We have a automatic cleaner, and I have actually
I request everybody to mute it because it may be coming. They are listening to some other, I think, thing. Please, everyone mute except Satyapriya and Siva, who are all the things.
Vital for the anchoring of the speculum.
I feel that's a very, very important point. And once I have made some problem 15 years back with the leak, and I have to pay with 1,20,000, but you have paid a very costly job. And one more
in the
thing, many of
mucosal layer of the
endoscopy and coming back, and
area
in the
above the dentate line.
medical college in West Bengal, we have
Satyapriya, just wait, just Satyapriya, just a
Yes.
minute. I think somebody is reaching the hemorrhoid stapling procedure. They are listening. Somebody is parallelly doing. Please stop your, audio, please, because it is disturbing our ear. Thank you. Now it's clear. Go on, Satya.
Yes.
Carry on.
Given medical college, especially 7 medical college surgery department, those who preach educated them, taught them, now they are doing regular. The worst part of them is, I have seen none of them are doing these things properly. The sterilization.
No, you've not left.
And
You're
that's
still
the
here.
very tragic
You've
part.
not
I
left
request
the
all
meeting.
the delegates, all who are there,
You're still
please
part of the
do
meeting. So
all
they
these
ask you a question. You won't know.
as doing a proper glamorous.
Yeah, sir. I
Leave?
think it may be.
Wait
Yes,
1 minute.
Shiva, if you want.
Just a minute. It may be. Professor BKR, sir, whether you are.
Go ahead.
Please keep it muted, please. I think there's some audio coming from your ASI meeting, if I remember right.
No, I'm not there now. I've come back to you.
Okay. Just somewhere it is coming back, tracking to
Yes,
our.
I just spoke to Kritika sir. She's finding out what's happening.
Yeah, thank you, Dev. Siva, any comments before we go for the next video quickly? Unmute yourself. Your tricks or your tips for cleaning and disinfection.
How the way we are decontaminating? What is the way we are for the decontamination? What we are using?
Yeah, decontamination is a very simple procedure. What we are using is a sterile water with a gauze piece. We are cleaning several times until there is no gross presence of a blood-stained saliva or a solution outside. 2 or 3 times, initially with the saline gauze, later with the Savlon or enzymatic detergents. Then you flush the channels or suck through the suction about 200 ml. That is a decontamination. Decontamination is before the leak test. Then you do the leak test. Then you do the brushing. Then you do the disinfection. So it is a process we do. You unmute yourself again. Siva, you muted yourself again.
In the laparoscopy, how we are decontaminating the instruments, the same way. What I'm asking is like decontamination is
immediately after.
Yeah, the people like the staff can touch without the gloves the instrument. That's what my per se what I say decontamination. So the decontamination, can we go for a hypochlorite solution in endoscopy? Laparoscopy, we are teaching like decontamination is using a 0.5% chloride hypochlorite solution. Using that decontaminate first before taking to the cleaning, pre-washing itself. Can we do that in the endoscopy?
Before COVID era, we are not used to hypochlorite as far as the endoscopy, flexible endoscopy is concerned. I request Roy and Professor Krishnarav's comment on using a chlorine for decontaminating the flexible endoscopy. Roy Patankar, I think you are still on. Please, your any comments on the disinfection, the way I described, whether you would do anything differently or you want to add anything, sir?
The only thing we do, the protocol of cleaning is the same. The only thing we do differently is once a week take a culture from inside the channel. And one of our ERCP scopes consistently grew Pseudomonas, and one bronchoscope 2 years ago grew atypical mycobacteria. So these are important points, and unless you have a protocol of doing your cultures yourself, you will not know this. So you could be giving iatrogenic infection to the patient, and unless you have a protocol of culturing your scopes.
Thank you. I think we'll quickly move on to the next video, small video, then we'll have further discussion.
You guys have 7 minutes left, Ishwar. 7 minutes.
Yeah. Exactly 6 minutes this video. So the most common problem for a beginner is to have a foreign body. Okay. So here you imagine there is a foreign body either in the esophagus or in the stomach. If it is in the esophagus, it ought to be removed within 24 hours. If it is in the stomach, you can wait and watch. Depending upon the type of foreign body, age group, there are so many factors. But esophagus, within 24 hours. If it is like a button battery, as soon as possible. If it is a sharp foreign body impacted, sooner is better. So like that, you need to make a clinical decision of
masterly inactivity or immediate attention. That is the thing you need to decide. Once you decide, now the removal of the foreign body is something like a common sense. And also you do what I call a dry run. If the father or a mother saying, my son has swallowed a 1 rupee coin, take a 1 rupee coin from your packet, try which instrument is good to catch it, fish it out. Try and adopt the same technique. That is one is a dry run. Second, do it at the odd time. Always have the same team, which is going to help you. 2 a.m. both your efficiency, your staff's efficiency is suboptimal. So you need to do the next day morning with the anesthetist presence. So don't hurry. Okay, this is the second important thing. Now let us go. I am having some instruments. Satya, you can come in now. And the foreign body, what are the philosophy of removal of foreign body in the upper GI tract? If I ask you to tell me 1 or 2 liners, what are the key important things you will tell? The take-home message for them.
Number one, the commonest foreign body we encountered all are the coins. And so you must have a very good grip so that while taking it out, you don't lose it in the pharynx and it doesn't go into the trachea and cause a choking. That's the most important point. So grip should be very, very fine.
You clearly said the importance of the second accident. That is, what was an innocuous foreign body, you make it as a dangerous foreign body if you just lose the grip as you are trying to withdraw through the cricopharynx. You nicely brought an important statement. Vijay, what is the main message you want to tell for the people who are trying to remove foreign body before they attempt, before we go in? What is the main important words of wisdom from you?
You must study what foreign body it is and how it is impacted. How is the lie of the foreign body, how much was the duration when it was lodged, so that we can know whether it has got fixity to the mucosa or the submucosa. The most important thing is all the foreign bodies in the children and also in the adults, as far as possible, they should be removed with endotracheal intubation.
Okay, I have now a 2 rupee coin in my hand, but it was in the patient's esophagus. You imagine. What is the best foreign body equipment you will ask your staff to keep it ready? I give you both 3 options. 1, I have a Dormia basket. 2, I have a Roth net. 3, I have a rat tooth forceps small one. 4th, I have a special, they claim it is a foreign body, the coin forceps. They claim. Under the coin forceps only I am holding here. And all other remaining things you know already, I don't think I need to describe. I'll show it in a minute. So which of the 4 you both choose? Each one, please. Satya, you start with.
I shall go for the Roth net because in my experience, Roth net, you can catch it, it never slips out.
What is your...
put a proper Roth net and then nicely catch it and then take it out. Roth net is my first preference.
Vijay?
Yes, actually, I often use a snare. If you, yes, I put the snare in such a way that it holds that rupee or a coin exactly at 12 o'clock and 6 o'clock, and then you tighten it up completely. Now it doesn't slip.
Okay, and depending upon the coin, whether it is in the esophagus or in the stomach, my approach may differ. And if it is in the esophagus, my first choice is going to be the coin forceps, which I'm having it in my hand. Okay, and I'm just going to ask my assistant to do the job of holding. See, for example, he is going to close. You just see how his hand, so your handle. So he is having like a cigar grip, thumb here, and like a cigar, he has to hold it here, approximate the fingers. As he approximates the ridge in the coin, and tight, hold it tight, and it is reasonably good, and you can see the grip. So it will not, and it should not come out of this, provided you maintain the tension in that forceps. So this is by far the best one, in my opinion, as far as the esophageal coin is concerned. The next bit, my feel, is a rat tooth forceps. Snare is good in an experienced hand, but it can slip out of it in the moment of crisis. Roth equipment is a very excellent instrument if the coin is in the stomach, because in the stomach you can't use all these things, you do more damage than good. So I'll just show the same foreign body with a Roth net. So the coin is on the stomach, somewhere in the fundus. You just go. The very important thing is how to keep it. Usually, you have to put it the convexity. See, this is the convexity. This is the concavity. You put the convexity on this, and then you just ask them to close it. Like close it slowly. And if you close it that way, then this is not only gripped nicely, it is also never going to come out. This is the surest, safest way of delivering it without dislodging it when it comes out of the cricopharynx. That way, I think Satya, what you said is absolutely right. But I especially, because it's difficult to do this maneuver, especially in a not a very roomy esophagus in a child. So I reserve this is specifically for a gastric fundal, foreign body like a coin. So this is about the removal. Dormia also sometimes is useful, but the dormia is for rounded objects. For example, this particular child has swallowed something like a piece of non-specific material, like a plastic one, which may not be seen radiology, like this one. This ideal is for again going to be like a Rothnet, or you can use a dormia. Just let us see with the dormia, because you have to treat it like a stone. Urologist, biliary people, they use right and left this dormia basket. Open fully. And make sure the dormia is quite nice. And just try to engage this equipment, close it. And once you have, because it is a 4-wire, it is better than a snare. All I can tell is, if you have a snare and also dormia, always a dormia is better, because with a 4 snare, with a 2-directional grip, the chance of slipping out of this is less, but still it is not as effective and safe like a Rothnet. So this is another one. The challenging foreign bodies are 2 I have in my hand. I want both of your opinion. One, you see something like this, okay, a 2A or 3A battery, or a pin in the esophagus. In the X-ray, it is looking like this. If you can't take it like this, it will cause a longitudinal tear if you're not too careful. So let us go with a pin now. Satya, what is the way? X-ray shows a pin in the mid-esophagus like this.
You have to go with over tube or a hood over the endoscope.
Yeah.
You must cover that one so that it doesn't, while coming out, it doesn't tear the mucosa or make a full thickness tear.
Forceps kuduma. Rat tooth
You
forceps.
have to cover the whole thing.
Out of the view.
If you go there and just unravel the hood over that one, and then you take it out.
There are 2 important things one has to do. I'll just try to demonstrate outside what we call a dry run. So the forceps, this is something like this. If it is there, you can catch it, for example, right? Catch it, open, close. You catch it like that. You push it inside. You just take it further into the stomach and dock it. Just open. You dock it. Then once you docked in the stomach, you reverse load it in the way you rather. In other words, you make the foreign body open, close, so that the sharp end should be trailing. It should not be coming forward. This is the first important thing. You take it slowly.
Absolutely agree.
And the second important thing is, don't rely only on this technique. Still, it can cause damage. So you can use something like what we have given is a fundal hood, which is actually applied reverse loaded. It's like this. So as soon as you come to the cardia, somewhere here, wait a minute. So it'll just, because it'll just go, if it goes through the cardia, and it will open up nicely like this. So the foreign body is actually hidden inside, and you can take the whole thing as a unit. So this is applied like this, like a hood, and then you reverse load it like this. Relax, loose. That's the
safest. That hood I also use.
Just 2 minutes more.
See, like this, you take it. So that way your vision is not affected. Once you take the foreign body, because you are coming to the cardia here, then it will let you just unravel, and it will go just like a protective sheath. It will come. The best place for a snare is whenever you have a tubular objects like this one. For example, It is very difficult. It is too big for anything I just said. Dormia, you may be lucky, but still, if you hold it right in the middle, it cannot come. It will be wedged in the esophagus. You can only take it this way. So the best way is to go, either push it into the stomach, then somewhere you just go, catch it. But the trick of the trade is to catch it somewhere in the junction of the last 1/3. Don't go in the middle. Open. Don't catch it here. Okay, then you will be coming this way when it comes to the cardia. Open. You catch it. I mean, if you see the batteries, they may have a small ridge. One of this bottom. If there is a ridge, you go and just go and encircle that ridge. Even otherwise, because of the firmness, and you will be able to go. And if you have the additional that fundal hood, you can put the hood, and it will see. For example, it can go this way, and the whole thing can come. Whereas if it is right in the middle, so hold it at the tip, use a snare, that will be the trick. Additional fundal hood makes it a complete success. Thank you.
I think that's everything. Deep, thank you. Siva, any comments before Deep takes over the final session?
There is no comments, sir. Like better than you, there won't be I don't think anybody can teach such in such a way, without even though you are imagining us it's inside the abdomen cavity or inside the stomach. Your demonstration is for the beginners. It's so good. Proud of you, sir. Thank you.
Thank you. Did you like it? I hope.
Beautiful lecture, beautiful demonstration. So everybody has been very much impressed with this. It's fantastic learning. And I think it's time that we go to the next session.
Yeah. I invite just a minute. I think the final one, I think we left it mainly to say the surgeons also sometimes come for the rescue for occasional endoscopic complications. To do this nicely, we have our real engine of our academic council, Deep Goel, along with the three heavyweight academicians. I think Dr. Pavanendralal, Dr. Randeep Wadhawan, our convener, Pauls, and also Baiju has been waiting quite some time, a global surgeon with the gifted hands and academic mindset. All three there, I am sure we'll have a wonderful final session. Over to you, Deep.
Thank you, Ishra. Also, I would take this opportunity to introduce my expert panelist, Dr. Pavanendralal, who is a very, very enthusiastic senior laparoscopic surgeon. He wears multiple hats. He's also, at this point of time, President National Board, and very close friend of mine, Dr. Randeep Wadhawan, who everybody knows, very senior laparoscopic, bariatric and GI surgeon at Manipal Hospital, New Delhi. Then we have, again, close friend Baiju, who is a very, very accomplished and talented GI surgeon from Trivandrum. Then also I'm taking the liberty of inviting my another close friend, Dr. Roy Patankar, since he happens to be here, and he's also contributed to as an expert panelist for this evening today. Roy, thank you very much. With this, I would like to start with my first case. This is a case of gastrocolocutaneous fistula following a peg placement. And this is an imaging gastrographic study very clearly showing that when you push the dye through the stomach, it is directly going into the colon. And this is the CT scan images, which again showing that how dye is going into the colon through the stomach. So with this, I'll show you a small video. What was done for this particular patient. You see, this is the stomach being hitched up to the anterior abdominal wall. So what was done? Catheter was removed, and we are, the surgeon is now trying to disconnect the stomach from the anterior abdominal wall by filing a stapler. Again, one can use suturing, but this particular surgeon has decided to fire. Now he's looking for a connection between stomach and the colon, and you can appreciate this fine track which is going along the tube between the greater curvature of the stomach and the transverse colon. And again, he's decided to fire a stapler after removing the tube, peg tube. So he has disconnected the stomach from the anterior abdominal wall. He has disconnected the colon from the stomach. So everything is done now. Everything is disconnected. Now he also needs to establish a way to feed the patient. So endoscopy is being done with an idea to inflate the stomach as well as check the integrity of the stapler. And then under vision, a PEG tube is being inserted and stomach being hitched. So I would like to ask Dr. Randeep how to prevent complications while putting a PEG tube.
Thank you, Deep, for the introduction and for the question here. So in fact, I was looking at this PEG tube complications, and I was looking at, how these complications occur, particularly these colonic complications. And surprisingly, what I found was that at times, these patients are completely asymptomatic. A splenic flexure would actually come somewhere in between the stomach and the anterior abdominal wall, and you actually go through both, and the patient continues the same. And when you try to change the PEG tube is when actually you find out that it doesn't go back into the stomach and it's going into the colon. So that's how you actually try to find out. So that can happen, probably not in this case. Again, you can prevent these complications primarily by ensuring that you have the endoscope, you have a completely inflated stomach in place. Once you are putting in the PEG tube, you identify, when you put in the needle, you aspirate and you see you're right there inside. At the same time, it can be, like we know that the PEG tube can actually be put both by the pull technique or by the push technique. Ideally, most of the people do by the pulling technique, by pulling in the thread outside and then guiding it on the guide wire and then pushing in the PEG tube over it. So the ideal way to avoid these complications, of course, is complete inflation of the stomach, which sticks to the anterior abdominal wall. Do it under complete guidance of endoscopy, and this complication in particular can then be avoided.
That's right. I think the complete inflation of the stomach is what is the key in this particular patient. Dr. Lal, after looking at the video, do you think something could have been done differently, or you think what the surgeon did was right for this particular case?
Thank you, Deep. Thank you for this kind invitation and for your introduction. I was only concerned about the way the gastrocutaneous tract was disconnected. I was not quite happy because there was no dissection done there to remove the remnant gastric mucosa around the skin, and that would continue to become a problem and continue to have a discharging sinus. So if I was there, I would have dissected this area around the whole fistula, and once that is done, that could have been disconnected. So that was my first point of difference.
Another thing which I was trying to see is that was it really necessary to fire the stapler on the stomach? He could have just simply disconnected the gastrocolic fistula after withdrawing the tube, and he would have left the PEG tube there. It would have served the purpose, because the problem is with the gastrocolic fistula, not with the primary tract. So I think that was another thing which possibly should have been done. Just fire the stapler onto the gastrocolic fistula and let
absolutely. I mean, I completely agree there that if you are, I was not quite clear what is the plan. So if the plan is to continue with the PEG, then of course there is no need to remove the first part of the operation to only the second part of it. It was completely, it was not apparent from the way it was going. But of course, yes, when you have to have the PEG in place, then there is no need to remove the first part of the tract and just remove the second component.
Yeah, but this is just to invoke a discussion that, these are the various things which you would like to do. You will have to plan your procedure, whether you want to dismantle the whole thing or you would like to just treat the gastrocolic fistula and continue with the original PEG. So this is just
but just one additional point. It may be because unless you disconnect from the abdominal wall, the mobility of the stomach, disconnecting of the gastrocolic may be difficult, technically putting a staple. Maybe for technical reason would have been done. Doing a PEG in an ideal situation, because that was in not an ideal place. Now we can choose the right place because he is doing everything under vision now. That could be the reason.
I completely agree. This is just to initiate a discussion that these are the various ways, then you really need to plan your procedure, what exactly you are wanting. As Dr. Lal was saying, if a repeg is not required, then what he did was right. And if it was required, maybe he could have considered this. But what you're saying is absolutely right.
I have another point there, from the way the fistula was located, it wasn't very clear that the mechanism was of incomplete distension of the stomach, because normally that is the way all endoscopists would do it. The location where you showed was as if this had eroded, as one of the mechanisms that have been described. It gets into the posterior wall, and then instead of during the time of insertion as well,
It's possible, but there was shown to be a long track between the colon and the stomach. So possibly this happened during the insertion, but yes, that is another way of how a fistula can form. Perfect.
Deep, can I interrupt?
Yeah, Beju, please.
Yeah, probably I would have done in a different way. Probably I would have done a scope and put an over the scope clips on it. Probably that will work without a surgery.
Endoscopic clip, you mean?
Yeah.
Possible. I think the chronic tracks, the clips may not work. When there's a track which is granulated, it is, the clips may not work, Beju. If it's an acute fistula or it's an acute rent, then the clips may work.
But there are
Ishwara.
Yeah. I think gastrocolic, clip will not work. I think there is going to be a high chance of recurrence. We have done one or two small tracheoesophageal fistula has been tried, but not in gastrocolic, in my opinion.
Perfect. I'll come to the next case, which is a 34-year-old lady with gastric outlet obstruction. There was a suspicion of malignancy, and she was stented since she was not willing for surgery, and the biopsy was negative for cancer. The multiple biopsies were done. They were not conclusive. And after 1 year, when there was no evidence of malignancy, and that is when patient and the gastroenterologist decided to remove the stent. So this is a video where endoscopic removal of the gastric stent is being attempted. And after when the stent has been placed for a long period, there is an ingrowth of tissues, and sometimes it is difficult to remove them. In spite of all the efforts by endoscopists, it was not removed. Then a laparoscopist surgeon was called, and what he did was he tried doing a transgastric laparoscopic method. As you can see here, this is through the laparoscope. We are inside the stomach. And now, with the help of a robust forceps and a grasper, trying to remove the stent. As you know, that endoscopic instruments are sometimes fragile and they don't give you that much of power to push or pull, and the stent starts breaking. So this is now double vision, laparoscope and endoscope both inside the stomach, and this is being removed. So this is again a perfect example of how surgeons and endoscopists can work together to solve a problem. So I would like to ask Roy, what are the difficulties you encounter while removing the stents endoscopically?
I think the first is never put a SEMS unless you have a tissue diagnosis of malignancy. It's unacceptable in a 31-year-old for a gastric outlet obstruction simply to deploy a self-expanding stent. The second, what I would do differently is I would do an anterior gastrotomy, evert the stomach out like you do a pseudocyst, and then removing that would be much easier, taking out my scope. I don't think it's... The problem really is in a biliary stent, when we do a Whipple's, taking it out is not easy because you're resecting that area. But in the stomach, I would find it very difficult to do what you showed. I would much rather do a wide anterior gastrotomy, remove the stent completely and close the gastrotomy under vision. That's an easier option, really.
What is your criticism of this particular technique? Because he did the same thing. He went inside the stomach and using a robust instrument, he removed the stent.
Yeah, I think it's just making just making an easy job difficult. You're hitching the stomach up to the anterior abdominal wall, putting a scope so that necessarily your access is less. You do a wide gastrotomy, suture the edges back together like you do for a big cystogastostomy, and then you have the stomach open for you. And then you have the proximal stent. You can use a stronger instrument and pull it out.
Okay. So it's a different, same thing doing by a different technique.
Correct.
Any other comment, Dr. Randeep, Dr. Lal, Baiju?
Yeah. Deep, can I make a comment here?
Please.
So just asking this question from Ishwar here really. Can you put in a stent within a stent and then wait for a couple of days and then take that stent out? Will that come out with this stent? I mean, you don't need to then do a gastrotomy. Is that an option?
No, it doesn't work that way. I don't think that is an option. In biliary, we used to do sometimes. For example, there are some occasionally when plastic stent migrates into the bile duct. The one technique we tend to use sometimes is you put a CRE balloon along, and inflated balloon, when you pull, the stent also comes on by the side. It is something that type of trick never works in this migrated stents. I think what they have done is right. What Roy said is a simpler technique. Extra two sutures you need to do, but it's much simpler because you have gone, whether it is a 2 centimeter gastrotomy or 4 centimeter doesn't matter. So you also do an easy job.
Unmute yourself, Dr. Lal, please.
I was just asking what was the final outcome? I mean, was there a outlet obstruction because that was not sorted? You know, removal of the stent. Was the gastroctomy done?
Since we are concentrating on the complications, this obviously they did a final procedure in the terms of GJ because this was a benign stricture.
Yeah, so then in that case, you know what Roy said would be the perfect solution. You know, do a gastrotomy and remove the stent and convert it into a GJ.
Absolutely. So I would go to the third case where this is a very interesting case actually. It's a case was done in one of the gastroenterology workshops where endoscopic gastrojejunectomy was being demonstrated. And while demonstrating endoscopic gastrojejunectomy, everything went off very well according to everybody. And later on, we got a call from endoscopist saying that there is a problem, you need to explore this patient. Unfortunately, I do not have a video of this particular case, but I have some pictures. And this is very clearly showing that stent lying outside the stomach. In fact, they could even never reach the jejunum. We traced the whole of the small bowel to see if they have done a GJ. What happened in this particular case is that the stent was put in, which came out of the stomach, but never touched the jejunum. So then we went in laparoscopically and removed this stent and just closed the defect. So that was a very simple procedure just to show that sometimes we can land into troubles. And they actually identified the problem immediately during the procedure and they called for help.
Can you clarify whether it is, was it an EUS ultrasound guided GJ?
EUS guided, EUS guided Ishwar.
Because they obviously want to do the lamp stent. This is one of the, I mean, theoretical complication one can have unless you are too careful. Yeah. Okay.
So coming to the fourth case, which is contributed by Roy, and I would request him to give the commentary for this particular case.
Unmute yourself, Roy. Yeah.
Any video and a single camera and some shooting with a hand camera. This was done at 1 in the morning. This patient was transferred to us from a town in Western Maharashtra about 14 hours after a achalasia dilatation with early mediastinitis. He already had a tachycardia and early SIRS. What we did for this gentleman was we put the CT scan showed a mediastinitis. So the idea was to do a mediastinal toilet as well as to repair the esophagus. In a minute, you will see me. The video is a little bit jerky. Is there a problem? You can see the perforated esophagus being seen when you did a thoracoscopy, and we found the two edges. I put a gastroscope down to identify the proximal end of the tear. This is obviously a balloon dilatation for achalasia. So we sutured the esophagus in a layer, then put a pleural patch on that, and then did a check endoscopy as well as an on-table gastrograph to make sure there is no leak in the esophagus. We then did we put 2 Riles tube in those days. We did a Frica tube, endoscopically guided it into the jejunum, and the other tube, 18-bore nasogastric tube, we kept in the stomach. And once this patient settled, after about 3 weeks, we did a transhiatal esophagectomy for this man because he had a huge sigmoid esophagus. And we didn't do it primarily because he was already in SIRS at that time. So this was a leak test that I'm doing endoscopically, and a second layer of sutures taken to close the mucosa. The mucosa you see is very bad. You're not getting good layers at all. There is some fungal esophagitis already there. So this is probably the worst situation to do it. But after getting a pleural patch on that, we showed no extravasation when dye was put intraoperatively. So this is an intra picture at 1 in the morning. So not a great picture, a single chip camera in those days. So the follow-up on this man was we fed him, gradually got him out of ICU off the ventilator, and 3 weeks later did a transhiatal esophagectomy for him.
So obviously
the discussion, the options would be a little different today, and I would be happy to hear from the others what I would have done today as opposed to 10 years ago.
Yeah, so Dr. Lal, how would you esophageal injuries post procedures? What is your protocol? How would you decide how to treat these patients?
So I would, I think it's a great job done, Roy. I mean, must say that compliments to you, and absolutely, this is 10 years back. But I would also say you were very lucky, because inflamed esophagus at 24 to 48 hours is the worst to put your sutures. So I think God was all with you and the patient that everything kind of stuck there. I would have converted this into, drained the mediastinum, drained the chest, and done a cervical esophagostomy. That would have been the procedure at my center, and then we would have taken a call later on.
Would you have considered putting a self-expanding covered stent on after closing this? Because we had to do a toilet, but maybe rather than doing a cervical esophagostomy, we could have put a covered stent in today's day and age after suturing the esophagus.
Also, in this particular case, because this was achalasia cardia, it will be difficult to keep the stent in place. That's another
What we
point.
do is usually take a string on the proximal end of the stent, bring it out through the patient's nose. And the idea is to temporize and stabilize the patient for 2 weeks till you get him out of SIRS and can do a formal transhiatal esophageectomy. Anyway, he had a huge sigmoid esophagus which needed a esophageectomy. So the stent would be the string be pulled out of the nose.
I comment?
I agree with Dr. Pavendra. If it was probably in our setting, I would have done esophagostomy with the toilet. But you are lucky, as Dr. Pavendra has told you, board was with you. You saved the patient, and congratulations to you.
So I know what you're saying is in line with the surgical principles, but I also have an experience of treating a lower esophageal perforation through thoracoscopy within 24 hours. And there also we took the stitches and we were lucky. So, sometimes, you may have to do a diversion, but there's no harm in taking the stitches and see how they hold up.
Yeah, we expect the fibrous tissue there after 48 hours. Probably we will not dare to do that primary closure of the esophagus thoracoscopically, frankly saying.
So this was 18 hours, Beju, and the patient was a 40-odd-year-old fit gentleman. So we took a chance thinking that we could always do a diversion stoma if required.
Very important, more than that of discussion.
Yeah. So what is mandatory in these cases is to do a thorough mediastinal lavage and drain the mediastinum properly. So even if it leaks, nothing gets collected inside, it comes out. Randeep, any point to make?
Yeah, just one little point. Of course, Roy has mentioned most of the things, and in fact, we've had an opportunity to suture within 24 to 48 hours, and we've gotten away with it as well, Buraves.
Exactly.
And so it can be done. Of course, esophagostomy probably is an option which is completely and 100% safe. But today, stent is an option. But why not think of feeding diagnostomy at this stage? You said you put in 2 Ryle's tubes. Why not a feeding J? Because if you want to wait for a few weeks, might as well have a good enteral nutrition there.
Yeah, a slightly different take on this. If this had been a Boraves and a patient had come within the first 24 hours, I would do a OTSEC clip. We have done that in the past. But this was an achalasia. So your options of suturing and OTS doesn't come too deep. But in a Boraves, if you come in the first 24 hours, definitely OTSE clip first. That actually is along with mediastinal toilet.
Thank you. So timing of surgery and procedure choice we have already discussed. So I will skip this slide. Coming to case number 5, very interesting case. This is a young gentleman who had pain abdomen and an upper J endoscopy was done. And they found a duodenal diverticulum, but unfortunately patient's condition worsened after the endoscopy, and X-ray abdomen done showed free gas under the diaphragm, and that is when we were called in. So this is a duodenal diverticulum. What we're trying to do is trying to dissect the second part of the duodenum, and you can see the fecal matter coming here. And that's the diverticulum which is being held up. So we're just trying to see that if we can reach the base of the diverticulum, where we can fire a stapler. Combination of blunt and sharp dissection, and once you get into the base, which is healthy, you just fire a stapler and just do lavage. Any comments on this, any one of us? Roy?
Immediate post-procedural endoscopy was it done? Just to check from inside things are okay?
Endoscopy was not done, but post-op gastrography was done on, within 24 hours, first post-op day.
I just want to put to the other panelist, is it doing with such a big staple line, doing an endoscopy required, or we can just put some methylene blue through the nasogastric tube and look on table? Why would you want to distend the duodenum in a very inflamed duodenum which you have stapled? I would be unhappy to do on-table endoscopy.
Since we were satisfied with the staple fire, we actually did not think of doing anything at that point of time. But you're right, Roy, one could have done a methylene blue test.
But can you tell me exactly? Exactly where was the diverticula? Is it a peri-ampullary diverticula? Was it close? I mean, I couldn't see it clearly.
No, it was not a peri-ampullary, it was in the lateral wall.
Lateral wall. Because when you fire, you want to see how close you are to the ampulla. That's why I'm interested in endoscopy.
No, it was on the lateral wall as it was shown on the video, and this patient had multiple diverticuli in the proximal jejunum as well.
Deep, another point is, would it have been worth cauterizing the duodenum to bring it up a bit further so you could see lateral to the diverticulum? That's one. And secondly, on the staple line, I would suture a piece of omentum on that deliberately, just as a kind of omental patch. Just me being paranoid, that's all.
No, that's perfectly fine, Roy. But since we went to the theater within 6 hours and there was not much swelling as you saw, so we were quite okay. And that is what we were trying to do. We were trying to cauterize the duodenum. But since we find the whole of the diverticulum with the hole and the normal base, so we didn't bother to go further. But yes, what you're saying is absolutely right, that ideally one should cauterize whole of the duodenum to really see what is the anatomy and how are the walls, and then fire the stapler. Any comments, Dr. Randeep, Dr. Beju? I'll move on to the next case then.
So this was well managed, well done.
Probably wouldn't have been able to do a stapler there because you will not get space for a non-diverticular patient.
Right. So this is a very big diverticle as you saw, and fortunately it perforated the apex rather than on the base. I think that is the reason we got away with this.
It's space for you to do a stapling.
Yes. Okay, this is the last case. This is a case after a routine colonoscopy. We had a perforation in the sigmoid, and obviously with the usual patient having distension, pain, and then investigation was done even in the recovery room itself, and we found out that there is a perforation, so we took the patient to the theater. I'm sure this is something which all of us have encountered at some point of time in our career. And that's the hole right at the mesenteric border. Just trying to see that there is no other hole, and this is only one hole which needs closure. When these holes are right at the mesenteric border, sometimes you are a little wary that whether you will be able to completely close it without compromising the vascularity. And we closed it in 2 layers. So technically there is no big deal in doing this. So rather than wasting time on this particular video, I will come to the discussion of this case. What are the high-risk cases for complications, Dr. Roy? Where can you preempt about this particular?
So I will be concerned about people with diverticulitis, or even sometimes you can have people with very floppy colons with a tight rectosigmoid bend. and I've seen some perforations occurring there. But beware of inflammatory pathology, or then when you're dilating a malignant stricture to deploy a colonic stent. That's another situation where I've seen perforation. When you do a balloon dilatation, your stent goes across, you think everything is fine, and post-op you have free gas on a diaphragm. So these are three situations where I have personally seen perforations.
Do you think any preoperative multiple surgeries in the abdomen leading to adhesions can cause multiple bends and make a high risk for perforation?
Not really. We do so many patients with multiple laparotomies, and there are screening colonoscopies happening across the world. I think that's not a good excuse. Previous adhesions. I think the key issue is if you go in blind, you don't look after the colonic bends, then you're going to get perforations. So stay in the middle and you're okay.
As Dr. Roy said, these are some of the common sites, rectosigmoid, transverse colons, or in a diverticular disease where, there's a lot of inflammation already, or a large diverticulum where you're confusing it with the normal lumen and you push to the blind end. And how does a colonoscopic perforation differ from other colonic perforations? Dr. Lal. Perforation done during a colonoscopy or a colonic perforation otherwise, how are they different?
Colonoscopic perforation from which other perforations you meant?
Any other colonic perforation which is not iatrogenic?
Yeah, so here the colonoscopic perforations could be, anywhere in the 360 degree, could also be on the mesenteric side, as you rightly said. Whereas normally on the other perforations where there are ulcers or, devitalization ulcers because of any disease, they all occur on the anti-mesenteric side. So from the location wise, I would say that colonoscopic ones could be anywhere and could also include the mesenteric. Now, in this particular case, this was the sigmoid, isn't it?
Yes.
So my management would have been converting this laparoscopic guided into a sigmoid colostomy. That would have been the way I would have managed it at my hospital. I would not have dared to close it primarily, even if it was within 6 hours or within few hours. That is the only thing, because we are on an unprepared bowel, or I don't know how much preparation was there in a sigmoid perforation.
So this is the precisely point which I wanted to brought to the discussion, that whenever we are doing a colonoscopy,
it's a prepared bowel.
It's a prepared bowel. So you can get away by doing a primary closure, and we have done a couple of them, and everybody we did a primary closure. And as compared to if it's a perforation more other than iatrogenic where bowel is not prepared, and that is where what you're saying is should be the protocol. Randeep, would you like to add something?
So I just
would like to add here. Please, Pawan, you go ahead.
I just wanted to add that it's not always that we so many times we do prepare the bowel, but the bowel is not that clean. So I think that assessment has to be done by the endoscopist at the time when we are doing the endoscopy, how clean the bowel is from inside. And if you have caused the perforation and you've aborted the procedure just short of seeing any other bowel, then you don't even know what is the proximal bowel cleanliness, how clean it is. In some cases, it is spick and span right up to the terminal ileum, and you are very sure. So I was just putting the being a little bit of caution, because it's being seen by youngsters also, that
fair enough.
You wouldn't be wrong if you were to do a lap guided sigmoid colostomy and consent the patient accordingly beforehand as well.
So when you go laparoscopically into the abdomen, and if you find contamination or significant fecal swelling, then obviously what you're saying makes sense. Randeep, please.
Yeah, Deep. So one thing I would like to add here is that I always suggest to our and we've done this, and we've suggested to our endoscopists that mark that area of perforation, in the sense whether it is with if they have the India ink, do it with that, or a methylene blue, just so that we identify where they perforated, so that that area is known to us. That's one. Two, I would have done exactly the same what you've done, since there is the element of peritonitis, and I would have exactly done the same. But there is theoretical that anything which is a perforation less than 2 centimeters, maybe an Ovesco clip can suffice as well. So that is something which is theoretically there. So I can ask the endoscopist to answer that. Anything less than 2 centimeters, an Ovesco clip.
Can I make a point, Deep?
Yeah, please.
Can I make a point?
Yeah.
Deep, I think we're getting a little carried away with Ovesco clips. I think once you have a colonic perforation, you have some degree of peritonitis. You need to wash the abdomen any which way, whether you have a clip or otherwise. So let's not get completely carried away with full thickness clips. We do full thickness clips quite routinely, but if there is a contamination, they need a good washout apart from suturing. That's the real key thing. And the second thing, I beg to disagree with Randeep. I would never want methylene blue or India ink put because it stains mucosa, and then closing becomes a real pain. We were doing this for achalasia, where we were putting methylene blue to check for leaks. And heaven forbid, if you do get a leak, then to identify the hole in mucosa is very difficult. So I would rather not put methylene blue. And I think always you can find a worst case situation, we don't find the perforation, put a scope on table and insufflate. Sometimes if you have retroperitoneal colon perforating, you just insufflate the colon, putting a colonoscope during the laparoscopy. So I would never.
May I add up?
Yeah, Beju, please.
Actually, a couple of occasions I had come across colonoscopic perforation done by myself. Actually, what I do and what I suggest is that you just put in a guide wire, throw the scope into the area, and immediately shift the patient to theater, and you find the guide wire inside by laparoscopy. And you can very well find out without even mobilization, you can suture that area, and you can infect the contamination also.
So 2 comments. One is, Roy, I would agree with you that I would not like to inject methylene blue or Indian ink. Second, there is a very interesting paper from Johns Hopkins where there are 28 cases of colonic perforations, which they thought were tiny, less than 1 centimeter, and they treated all patients conservatively. The morbidity and the hospital stay was much longer as compared to people who were treated surgically of perforation of any size. So I think what you're saying is right, that once there's a colonic perforation, I think it is a good idea to take the patient to theater as early as possible and do the peritoneal toileting as well as close the perforation or colostomy, whatever is required for that particular patient.
There is paper also to suggest that people who've perforated and they've identified it right there, they've put in Ovesco clips, not just in sigmoid, even up to transverse colon, and patients have been fine and they've got enough data to suggest that. So what I said, I would probably do the same what you did, but at the same time, for a discussion sake, somebody identifies, can put in an Ovesco clip, that, and up to 2 centimeters they've done. And that's a paper which is published just last year.
So we must not forget that all these patients are coming from gastroenterologists itself. So I'm sure they have explored the possibility of putting all these clips, and when they think they're not confident to obviously everybody would like a more definitive treatment and more established treatment in case of complication. But I take your point, maybe in the future as technology develops more, maybe these small perforations in a well-prepared bowel maybe can be treated by endoscopist itself. I think I am through. The mechanism of injury, as we all know, is because of blind pushing and applying force. Whenever there is acute pain or there is a inflammation, this leads to injury. I think I'm through with this. If there are any comments from any of the panelists, please.
I have a small 1-minute video how a colonoscopy perforation happens for the beginners. Just can I share now?
Please,
just stop sharing. I'll just quickly
Can I have your permission to leave? There is a meeting which I need to
Pavan. Yes, Rolal, I'm joining you.
Thank you so much. Thank you, everyone. Thank you, sir.
And we have another session to conduct here.
Yes. As you can see here, this is actually a patient, elderly lady who had a abdominal hysterectomy 5 years ago, came with obstructive defecation, well-prepared bowel, and one of the junior colleague of mine was trying to do, as he was going into the rectum, and he was trying to distend. As you can see, the bowel is well cleaned. It's a very good bowel preparation. And he was going very close. Whenever you see where we are going out of focus, very close, and blanching happens. See, this is the very time. You can see now, typical extraperitoneal, that space you create in the laparoscopy. This is what you have. You have gone into the posterior wall and got a full thickness. A diagnostic colonoscopy causes a bigger perforation rather than a polypectomy or even a ESD. That one has to understand. Second, perforation can be free peritoneal cavity, or like here, it could be through the mesocolon. But it is very difficult to be 100% sure whether it is only through the mesocolon. So we did immediately this particular patient. See, for example, this is what happened. The A, that is, he has gone directly into the posteriorly like this. but perforation can happen with a kink in the the scope also, or just below the stricture, or excessive insufflation. There are various reasons because of our inexperience, blind force, or high risk case like our case of pathologically fixed rectosigmoid junction because of previous hysterectomy. That one has to understand. And this is the X-ray we had. You can see a lot of air. So I was a bit concerned. I didn't want to wait too long for this patient. As Pawan was saying, we didn't do all this experimental procedure. Conventional wisdom prevailed. We went for a laparotomy. We saw a lot of inflammation. We washed out and we saw a large hole. So we had to risk, because that area was kinked. So we had to resect a sigmoid colectomy, mobilize to do a primary anastomosis. We didn't venture into the endoscopic intervention in the patients. So for beginners, you need to be very gentle, especially a patient with the previous lower abdominal surgery, colonoscopy. You don't blindly push across any blind ends. Sensitive to the patient discomfort, very, very important. Don't over sedate. Sedation is not the answer for a difficult colonoscopy. That's the message I want to give it. And over to our people. Dave, anything you want to add before we go for the final vote of thanks?
Thank you so much for showing the last video. And I think it's very important for all of us to understand that however simple is the procedure, even if it's just a simple diagnostic endoscopy, one must follow the principles. One must be gentle, and as you very rightly said, if you are struggling or if patient is struggling, do not over-sedate the patient.
Thank you.
Yes, I think I would like to thank all my panelists for being there and for giving all valid answers. And I would like to hand over the mic to Ishwar.
Thank you, Dev. I think you agree with me. We had a very fantastic 3 hours with the endoscopy masterclass. Thanks to all our faculty. I have the pleasant job of doing the vote of thanks now, a couple of minutes. I think we all agree that we started with the endoscopic rescue, went all the way to 5 different sessions, trying to impart the knowledge, and the take-home message for all the budding surgeons are 2. That is, there is no scope without a scope, be it an endoscopy or a laparoscopy. From today onwards, endoscopy, laparoscopy are 2 eyes of every surgeon. With that message, let us go with an open mind. When a patient comes with any problem, be a surgeon, endoscopist, interventional radiologist, or primary physician, keep the patient at the center. It is a collective responsibility. We don't compete each other. We should be complementing each other with the patient care. That's the only way we can do this. So it is a win-win situation both for the endoscopist and surgeon as a altogether. So IAG is very proud to propagate this particular concept. Thank you all. Thank you for Doc Plexus, Kirtika, and the team Doc Plexus for showing this seamless transmission. We really enjoyed this 3 hours of discussion. Thank you, Dev. Thank you, Sayanda, our chairman of the Academic Council. Thank you.
Thank you. Thank you, everybody. Thank you.
Thank you.
Thank you very much. Enjoy the Sunday evening now.
Thank you. Thank you, Sunil.
Thank you.
Thank you, Randeep.
Thank you.
Hello.